Good morning, and welcome to the seminar. Really appreciate the Epilepsy Foundation doing this and giving me an opportunity to be in front of you guys to talk today about evaluation of drug-resistant epilepsy, what to expect in the epilepsy monitoring unit. So this is there also? Yeah. Okay. So what are we trying to achieve with the talk today? We're going to try to identify what is drug-resistant epilepsy, understand and educate patients on what the definition of epilepsy is, morbidity and mortality associated with the drug-resistant epilepsy. Then switching gears to the epilepsy monitoring unit, why patients should be referred to the epilepsy monitoring unit, and understand the elements of the epilepsy monitoring unit. What does it entail when our patients come into the epilepsy monitoring unit? What can they expect from the epilepsy monitoring unit? I just want to go over some of the very basic definitions that we use in seizures and epilepsy. What is a seizure? A lot of the times when the patients have a seizure or they're told that they have a seizure, first thing that comes to mind is, what exactly is a seizure? What is my doctor talking about? So seizure is a transient disruption of cerebral function due to disruption, abnormal and excessive discharges in the brain cells. So what happens is that there is brain cells that excite and there are brain cells that inhibit. Normally there's a balance between the cells that excite and the cells that inhibit, so we don't feel anything. But sometimes what happens is when there's a seizure, there's a disturbance in this balance. So then there is more excitation and it crosses a threshold, and that culminates into an electrical storm, which just wipes out a part of the brain function, and that results in a seizure. So seizures manifest in different ways. A lot of us, we are familiar with seizures where we get stiff, we go into convulsions, we drool or froth at the mouth, we bite our tongue, things like that. But that's not the only way the seizures manifest. Seizures manifest in a variety of different ways. Seizures can be where you just stare off into space. You just become unresponsive. You don't know where you are. You get confused. Then there are some seizures which have like non-purposeful movements, which we also call as automatisms, where you have like chewing movements or swallowing movements, or you just fumble or you pick on things all the time. Or you might start dressing, start running, start walking. So those can be varied manifestations of seizures. Then there are also seizure types where you're standing there and you just have a convulsion, like a myoclonic jerk. And people normally don't pay attention to it, but when they come into my office and I start talking to them, yeah, I think I have those, especially when I go to bed at night or when I wake up in the morning. Keep in mind, those can be type of seizures as well. Some unusual seizures where you just keep laughing. Gelastic seizures, they can also be manifestations of seizures. Then we go to what is epilepsy? Seizures is one, epilepsy is another. What is the basic difference between the two? Epilepsy, for a long time, we've considered that anybody who has two or more non-provocative seizures or unprovoked seizures have epilepsy. So the task force of the International League Against Epilepsy first met in 2005 and came up with this definition. So this definition, which it says there's an enduring predisposition to generate epileptic seizures. That means you're going to have seizures no matter what. Whether or not there's any provocation or not, you're going to have more than two or more seizures. That's epilepsy. This is a very theoretical definition because we could not individualize which person was going to have seizure, which person was not going to have seizures, and when do they outgrow their epilepsy? So this definition did not answer most of those questions. So the task force again met in 2014, last year, and they came up with a new definition. So there are three main features of this definition, which I'd like to go one by one. Now the first item, at least two unprovoked seizures or reflex seizures, greater than 24 hours apart. This is exactly what the first definition said in 2005. But what's interesting is the second part, which says one unprovoked seizure and a probability of further seizure. If this probability exceeds greater than 60%, even after first seizure, if your doctor sits down with you and says, you have an abnormal EEG, there's something on your MRI scan, there's a lesion on the MRI, you have a strong family history. So when your doctor puts all this together and say, look, though you've only had one seizure, I think you have a greater chance of having a second seizure. We should treat it. Why he's saying that we should treat it? Because he thinks that you have epilepsy. So this definition includes that thing. because in the first definition, you had to have 2 seizures to become epileptic. But according to the new definition, even after first seizure, if your risk is high, greater than 60%, you need to be treated because you might have epilepsy. And third is a diagnosis of an epilepsy syndrome. So we know that there are certain epilepsy syndrome, like benign Orlandic epilepsy with central temporal spikes. So this definition says epilepsy is considered to be resolved for individuals who had an age-dependent epilepsy syndrome, but are now past the applicable age. What it means is that most of these epilepsy syndrome, like benign Orlandic epilepsy that I talked about, a lot of the patients grow out of these seizures at age 16, and most definitely by 21. So if a patient who has the seizures and say is 23 years old, hasn't had a seizure for several years, their epilepsy is considered to be resolved, according to this definition. Now, when you tell your patients that your epilepsy is resolved, keep in mind, they could still have seizures. It doesn't always mean that once you use the word resolved, they can never have a seizure. All this definition is saying is that the chances of having another seizure is very small, almost none, to the point that it can be considered that the epilepsy is resolved. So that's the new definition of epilepsy, which we use now. I want to talk about drug-resistant epilepsy. So drug-resistant epilepsy, as the name implies, is basically epilepsy which continues despite anti-seizure medications. So patients who are on 1, 2, 3, 4, 5 medications and they continue to have seizures are considered to have drug-resistant epilepsy. So we use other terms like intractable, medication-resistant, or pharmacoresistant epilepsy, but the International League wants us to use the term drug-resistant rather than medication-resistant epilepsy for these patients. Let's try to look at the first line, which is the definition of drug-resistant epilepsy. What is drug-resistant epilepsy? Let's break down this definition. Failure of adequate trial of 2 well-tolerated, appropriately chosen. Adequate trial means that the patient has taken the maximum well-tolerated dose of the medication. I will have some patients come into my office and say, Doc, I'm still having seizures, and when I go back and look at the medications, what they've tried, let's take an example of Keppra. Keppra, like Dr. Chung said, is the most widely given anti-seizure medications. So when I asked them, what dose of Keppra did you take? Well, I took 500 milligrams twice a day. Did you have any side effects with the medicine? No, I didn't have any side effects. So why did you get off the medicine? Well, my doctor said I was still having seizures, so he took me off of Keppra and wanted me to try a different medication. So this clearly shows that whoever the treating physician was did not try a higher dose of Keppra than 500 milligrams twice a day. It's not even considered a therapeutic dose of Keppra. So the definition says that she should have tried adequate dose of 2 tolerated, appropriately chosen. What does appropriately chosen mean? Dr. Chung told us that there are seizures which come from either one side of the brain, which are partial onset, or from both sides of the brain, which are generalized onset seizures. So there are certain drugs that act for partial onset seizures, and there are certain drugs which act for the generalized onset seizures. So if you put on a drug, all right, let's suppose you have partial onset seizure, and you will put on a drug for generalized onset seizure, it might work because it's a broad spectrum anti-seizure medication. On the other hand, if you have generalized seizure and you have put on a medication which has partial onset seizures, it might not work. So there, you were not given a drug which was appropriately chosen and administered, meaning that if the drug was to be given twice a day or 3 times a day and you only decided I'm going to take it once a day, that's not an appropriately administered drug. Or sometimes you can't keep your medications down and you need medications through the IV. So that's what the definition means, that you have to have an adequate trial, 2 well-tolerated medications, appropriately chosen and appropriately administered to achieve seizure freedom. If you've done all that and you still continue to have seizures, that's drug-resistant epilepsy. Now, traditionally, we used to consider that patients who have tried 3 different anti-epileptic medications have drug-resistant epilepsy. But now we have several studies to prove, and in fact, the landmark study by Quan and Brody in 2000, which clearly showed that patients respond best to the first medication. More than 50% will respond or become seizure-free after the first medication. But when you try the subsequent medication, the second and the third and the fourth medication, that number goes down. And from 50% with the first medication, it goes down to almost 15% or 20% with the second medication, 15% with the third medication. So if your patients are only going to respond, or have a chance of responding 5% to the new medication that you're going to try them, number 3 or number 4, why do you want to try that medication? So we're going to talk about how we're going to think outside the box. How are we going to try different other treatment modalities for these patients? So what are the risk factors for drug-resistant epilepsy? Who is more vulnerable to develop drug-resistant epilepsy? So we said response to the first AED. We just quoted the Kwan and Brody study. So if you responded well to the first antiepileptic medication, you're probably going to do well. But if you've not responded well to the first antiepileptic medication, the chances are you won't probably respond to the second or the third or the fourth or the fifth medication. So the response to the first medications will tell us a lot about how our patients are going to do in the long run. The high number of seizures before diagnosis and treatment. So the patients are having several seizures before they come to see you. You know in the back of your mind that this patient is probably not going to do well with just the medications. Etiology of the seizures. Now we talked about the generalized seizures and the partial seizures or the localization-related seizures. Now, if you go back and look at the data, the generalized onset or the idiopathic type of generalized onset seizures have actually a good prognosis. Juvenile myoclonic epilepsy, patients respond very well to medications. But on the other hand, if the patients have localization-related epilepsy, which are not of the idiopathic type, then they do not have that good chance of responding to medication, and there are more chances of developing drug-resistant epilepsy. Now, interestingly, localization-related epilepsy, which is related to vascular lesions, they actually respond better to seizure medications as opposed to patients who have the scar tissue or mesial temporal sclerosis. That's considered to be one of the most resistant type of drug-resistant epilepsy. So we'll talk more about that. Then you have patients who present with, say, status epilepticus, where they continue to have, yes? Right, we take care of, we have to look at all of those things. Well, like I said, the tolerated part looks at the side effect profile. So if the patient is having side effects, obviously that's not good. So you have to take them off the medication. All right, then we were talking about certain patients who present with status epilepticus at the onset. Those are the patients who do not have good chances of being seizure-free with medications. Longer duration of epilepsy, like we talked about. A strong family history of epilepsy is, again, a risk factor for developing drug-resistant epilepsy. Febrile convulsions as a child could be related to drug-resistant epilepsy because it could be related to mesial temporal sclerosis that we talked about. And abnormal EEGs. Now, just because you have an abnormal EEG does not mean that you have increased chance of having drug-resistant epilepsy. But when you put it together with the other factors that we talked about, that does increase your chance of having drug-resistant epilepsy. So what is the pathogenesis? I mean, what actually happens in the brain that causes drug-resistant epilepsy? So like I said, we studied the model of MTS, which is mesial temporal sclerosis. It's an evolving process. If you look at the pathology of the mesial temporal sclerosis, there's glial proliferation and dendritic sprouting and synaptic reorganization happens in the brain. We don't have to remember that. In animal models, we've seen that there is altered drug expression of AED targets, as well as morphological alterations in the hippocampus, which is considered to be one of the most highly epileptogenic area in the brain. So we do see some alterations there. Now, this is in the animal models. I mean, have we extrapolated this to the human beings? Probably not, because we don't have good data on the human beings. And secondly, we really don't know whether this is actually the cause or actually the effect of the drug-resistant epilepsy, all these changes that we are seeing. Is it the cause or is it the effect of the epilepsy? How do we evaluate? I mean, once you know the patients have drug-resistant epilepsy, they come to you, what is the next thing? What do you want to do for these patients? As a rule, we in epilepsy community strongly feel that all these patients, when they come to you and they're telling you that they continue to have seizures, what you want to do is, number one is confirm the diagnosis. That's number one. Because a lot of time it happens that patients may not actually have epileptic seizures. Patients may have non-epileptic seizures, psychogenic seizures, or seizures related to stress. Then you want to see what the type of epilepsy is. Is it the partial epilepsy? Is it the generalized epilepsy? Are they on the right type of medication for the seizures? And then lastly, for surgical evaluation, which is very important. Every patient who has drug-resistant epilepsy should be given a chance for surgical evaluation, should be given a chance to see if surgery will cure them of their epilepsy, because that's the only cure for epilepsy. The neuroimaging, a lot of the patients who come to us who have drug-resistant epilepsy have had MRI scans of the brain at an outside facility. We always want to make sure that the MRI is done using an epilepsy protocol. So if you go to your doctor, you go to a neurologist who's ordering an MRI scan because you have seizures, insist that you want an MRI with an epilepsy protocol. So because it takes certain sections in the MRI that actually will highlight these abnormalities in the brain that otherwise will not. And make sure that the MRI is read by a neuroradiologist. Because there's good data and studies to prove that MRIs that were read at an outside facility by doctors who were not trained to pick up those lesions on the MRI actually missed those lesions. So when they came to the seizure center and we looked at those MRIs and our neuroradiologist looked at the MRIs, we would actually pick up those lesions on the MRI scan of the brain that were missed. So insist that the MRI is done using an epilepsy protocol. Can we save the questions for the end? Is that okay? However, if the MRI does not show any lesions, I mean, what are the other options? What are the neuroimaging studies that you can do? We can do a PET scan, we can do SPECT scan, SYSCOM, which is being done at the Mayo clinics mostly. Then the other important thing I always tell my patients is to maintain seizure diaries. I mean, it's very important for the patients to keep a log of all their seizure activity. Very important. Just like the headache diaries, the seizure diaries need to be with you when you go to see your doctor. On every visit, take your seizure diary and insist that your doctor look at your seizures. There are some patients of mine who are so compulsive, they will write every day, not just when they had a seizure, every day what happened. And she'll come with 20 pages, and I go over those 20 pages and I say, what actually tells me about that diary is that, what else is happening with her besides seizures? What is she eating? Has she made any changes in her diet? Like Dr. Chung said, did she have too many donuts that day? I want to know. So she'll write down what she ate that day. She's so compulsive about it. Or what is the sleep patterns? What time did she go to bed? What time did she wake up? Is she getting enough sleep at night? So those are all the things that you want to go in the seizure, want it to go in the seizure diary as your patient drinking alcohol. Even if they drink alcohol, tell them to write down in the diary that they have 1, 2, 3, 4, 5, or how many did they have? Are they using any drugs? Put them in the diary. So seizure diaries is very important when you're evaluating patients with drug-resistant epilepsy because it tells you what is going on in their lives besides seizures. Is anything else having an impact on seizures besides just the seizures? Because before you get too excited and start to do surgical evaluation, if you look at the seizure diary, maybe they're doing something that you can correct in their lifestyle that might help with their seizures. That's the importance of the seizure diary. So what are the treatment options for these patients? Resective surgery, by and far, is the best treatment of choice. So the treatment of choice for patients who have drug-resistant epilepsy, which is a lesional partial epilepsy. Dr. Zimmerman is going to be talking more about the surgical aspects of the epilepsy after my talk. But in a nutshell, I mean, epilepsy surgery or resective surgery has almost 80 to 90% seizure freedom rate in patients who have mesial temporal sclerosis or the temporal lobe type of epilepsy. So anytime you see these patients who have a scar tissue or mesial temporal sclerosis and the seizures are coming from that part of the brain, always consider epilepsy surgery because you can really make a difference in their lives. There are other types of surgeries besides the resective temporal lobe or amygdalo-hippocampectomy surgeries. You can have corpus callosotomy. You can have subtial transection. So different surgical types have been offered. And most recently at Mayo Clinic, they're also doing the laser ablation, which again, Dr. Zimmerman is going to be talking about. Then the other treatment modality is the vagus nerve stimulation. Vagus nerve stimulation was approved back in, I think, 96 for refractory epilepsy in adults and children older than 12 years of age who have partial epilepsy. So what that entails is implanting a stimulator right under your collarbone on the left side. And via cable, it is connected to the vagus nerve, and then we can program the stimulator to send the impulses to the brain. So it's a reasonable option for patients who are not surgical candidates or who choose not to have surgery. Because when you tell certain patients, look, we're going to take a part of your brain out, they just take a step back. Oh, nobody's doing any cutting on my brain. All right? So then you say, all right, if you don't want surgery, vagus nerve stimulation is an option. Or vagus nerve stimulation is also an option if you've had resective epilepsy surgery, but unfortunately you still continue to have seizures. Then there's an option to do the vagus nerve stimulation for these patients. I'll go to anti-epileptic drugs later, but cortical stimulation or responsive neurostimulation is the new treatment modality that was approved in 2013. It's a closed-loop system which is actually coupled with a seizure detection system. So it's a great treatment modality for patients who continue to have seizures but have a well-delineated seizure focus. So what this does is it detects the seizures coming from that part of the brain and sends more impulses or targets more impulses to that particular part or area of the brain. So it's a good option for patients if you have spikes or discharges coming from both sides of the brain. Obviously, your doctor is going to tell you, look, you're not a candidate for surgery, but you may be a candidate for responsive stimulation. Or if your seizures are coming from, say, eloquent cortex, that means the part of the brain which controls your speech. So you don't want anybody to resect that because you don't want to lose your speech. So it may be a good option for these patients, the responsive stimulation. Then the anti-epileptic drugs. So we keep going back to, well, if you've tried 2 anti-epileptic drugs, your chances of becoming seizure-free after the second and the third and the fourth continues to go down. But, I mean, if none of these options is available to you, you're not a candidate for surgery, you've tried vagus nerve stimulation, didn't help, you're not a candidate for responsive stimulation, but maybe we'll have to consider anti-epileptic drugs for you. So we talked about more and more drugs that are coming out, and more of these drugs have better efficacy than the drugs we've tried in the past. They have less side effects, or patients can tolerate them better, so it might be a viable option. And then most of us, we do trials with investigational drugs, which are in the phase 2, phase 3 studies, so we can actually have our patients try some of those medications to see if they become seizure-free. Ketogenic diet is a viable option, especially in children. It's a high-fat diet, low protein, difficult to swallow, but some patients will have to take it because the seizures are not very well controlled. It's mostly an option with children. And it has been shown that in about 1/3 of the patients who take this have a greater than 50% seizure reduction. So it does work. Lastly is cannabinoids. There's a good talk, I think, at the end of the day about cannabinoids on this, so I'm not going to touch more on those. But the jury's still out. We don't know whether it still works or not, but we'll hear more from the speaker whether or not we have anything new on the horizon. When you talk about drug-resistant epilepsy, you have to talk about autoimmune epilepsies. This is a new area that we, as epilepsy specialists, have started to look into with our patients who continue to have the seizures despite being on anti-seizure medications. So we're all familiar with autoimmune disease. If not, there are several autoimmune diseases that affect mankind: diabetes, multiple sclerosis, thyroid diseases, Hashimoto's thyroiditis. So we knew that the autoimmune diseases are in some ways related to the seizures. But we also know, with the new information that is coming out and with the antibodies that we are now detecting in our patients, that there is more correlation with autoimmune illnesses. I mean, the classic example of autoimmune illnesses used to be limbic encephalitis, where patients would be very confused and continue to have the seizures. That was limbic encephalitis. But now there's more and more evidence that patients don't have to have that extreme of a disease of the limbic encephalitis, but they could still have their epilepsy related to the autoantibodies or the autoimmune illness. So what is autoimmune illness? It's frequent or medically refractory seizures that we talked about, that they continue to have the seizures despite being on anti-seizure medications, presence of at least one neural antibody. We'll talk about that antibody. When you do spinal fluid testing on them, there's signs of inflammation. Their white cell count is high, their protein may be high, their IgG index may be high. Or there's signs of inflammation on the MRI, that you will see changes on the MRI. They'll see white matter changes on the MRI, which is signs of inflammation on the MRI. And they might have a personal or a family history of autoimmune illness. So when you group all these together, you have to think about autoimmune illness. That means there's something else going on besides their seizures that's contributing to the seizures or not letting them become seizure-free. So there is treatment options for these patients outside of anti-seizure medications, outside of epilepsy surgery, outside of vagus nerve stimulation. These are the patients who will respond to immunotherapy with medications that will increase the chances of becoming seizure-free. So we as epilepsy specialists are now starting to look that way, this way, and focusing more on those. And especially when these patients have an acute, let's look at the clinical features. They have multiple seizure types, sometimes a facial-brachial type of seizures, which involve their face muscles. They have drug resistance to medications. They might have a history of cancer, either in the present or in the past. They might have a viral prodrome. But the last feature is most important. When patients come to you complaining of having memory loss, young patients, I recently had a patient who kept insisting, my memory is not very good. She was only on one seizure medication. She's working, but she keeps saying, my memory is not good, my memory is not good. That's when we started to look into autoimmune epilepsy in her case. And sure enough, she tested positive for that. Personality change, thankfully she didn't have a personality change, she's still working as an RN. Depression, anxiety, those those features can also be associated with autoimmune epilepsies. So these are some of the neural antibodies. There are about 20 of those that we've identified in our patients who have autoimmune epilepsies. Autoantibodies to NMDA receptors, voltage-gated potassium channel complex, AMPA receptor that Dr. Chung talked about with Brempinel, GABA-B, glycine, and GLU1 and GLUR5 antibodies. So those are the antibodies that we can isolate that actually Mayo Clinic offers the testing on them. Athena Diagnostic Lab actually offers a battery of tests where they will screen the patients for all the antibodies. So it's a simple blood test that will screen the patients for all these antibodies. So the point I'm trying to make here is that when you have drug-resistant epilepsy, you have to consider autoimmune epilepsy as a clinician. As a patient, you have to know, and you have to be more proactive about it, that has my doctor tested me for all these conditions or not, before he's thinking of doing epilepsy surgery on me or implanting a vagus nerve stimulation or other treatment modalities. So when you have drug-resistant epilepsy, there are going to be complications of that. And patients who continue to have seizures, they're going to have problems related to the seizures. If you look at the mortality data, 1.37 per 100 years, that means there's a high chance of these patients can actually die from seizures. So we as clinicians, we want to make sure that we control their seizures as early as possible. And the interesting fact is that it reduced their life expectancy by 19 years. So for us, when we're talking to our patients, our goal is total seizure freedom, because we know that if we completely get rid of their seizures, we can make a huge difference in their lives. SUDEP, or sudden death in epilepsy, is 40 times more common in patients who have drug-resistant epilepsy. It's a topic by itself. Drug-resistant epilepsy also increases your chances of non-fatal injuries, hip fractures, which is not uncommon in our elderly patients. They have seizures, they fall, they break their hip. Or head injuries is not uncommon. Burn injuries is not uncommon in these patients. We all know that it increases disability. A lot of our patients who continue to have seizures, they can't be gainfully employed. That's the sad part. They can't drive. So it really limits their lifestyle. It really decreases their quality of life. And obviously for our young patients who want to go to schools and colleges, there's poor academic achievement because of continued seizures or because they're on several different anti-seizure medications that definitely delays the thought process. Then there are psychiatric comorbidities. Depression is a very common comorbidity with seizures. So we as clinicians, when we sit down with our patients, our question is always about mood. We cannot ignore it. Anxiety, heightened anxiety, either because of the seizures itself or because of the medications. So we have to be careful that we choose the medications appropriately in these patients. Social dependency is not uncommon with these patients. So we have to be, as clinicians, when we talk to our patients, we have to make sure that we talk to them about this and try to address this. I mean, if some of us, we feel comfortable addressing those with the help of some medications, but other times we might have to get the help of a psychiatrist or a psychologist or other people who can help them out. So let's switch gears. We talked about drug-resistant epilepsy, and the second part is the epilepsy monitoring unit. So what is an epilepsy monitoring unit? Has anybody sitting here ever been to an epilepsy monitoring unit? All right. So epilepsy monitoring unit are basically designated areas in the hospital where we bring in patients to better study their seizures. So what we do is this is a long-term EEG video monitoring. So the patients come into the hospital, we hook the wires on, they're on the camera, so we continuously monitor their brain waves, and they're on the camera, so if they have a seizure, so the seizure video is time-locked to the EEG, so we can look at their brain waves when they're actually having a seizure. Keep in mind, this is the litmus test. If you're having seizures and your EEGs have been coming normal, doesn't mean anything. You could still have epilepsy or you could not have epilepsy with a normal EEG. But if you continue to have the seizure, your doctor has to bring you into the epilepsy monitoring unit to better study your seizures, study what part of the brain they're coming from. So why do we bring patients into the seizure monitoring unit? Let's look at that. Seizure diagnosis, like I said, the most important thing is always confirm the diagnosis. Are we really having epilepsy, or are we having psychogenic non-epileptic spells? So when we bring the patients into the monitoring unit, interestingly, about 20 to 25% of the patients in the monitoring unit across the country do not end up having epilepsy or real seizures. They have psychogenic non-epileptic spells. So these patients don't need to be on seizure medications. The treatment for the psychogenic non-epileptic spells is totally different. So you just took them off of those 10 seizure medications they've been on for the last 10 years. I'm sorry? Oh, speak up. All right. So, psychogenic non-epileptic. So we can actually take them off of the seizure medications that they've been on for their entire life. But at the same time, patients who have epileptic seizures, we can actually define what part of the brain the seizures are coming from. So seizure classification, whether they're partial, whether they're generalized, and most importantly, surgical evaluation. That's the part where we want to see. Every patient should be given an opportunity for surgical evaluation. Because we know, after having tried 2 or 3 or 4 medicines, we have to think outside the box. We have to think about other opportunities for our patients. So surgical intervention is number 1, followed by vagus stimulation and others. So in the epilepsy monitoring unit, this is my team of technicians at the Epilepsy Monitoring Unit at Banner Boswell Hospital. We have a 4-bed monitoring unit. So like I said, it's a continuous long-term EEG video monitoring. So what can you expect when you come into the epilepsy monitoring unit? First is we take you off of the seizure medications while you're in the monitoring unit. Not everybody, but most patients need to be taken off of the seizure medicine because remember, it's a controlled environment. Our nurses, our technicians are watching you 24/7. So if you go into a seizure, they're going to rush in, give you the medicine, stop the seizure right then. So our purpose in the epilepsy monitoring unit is to sample a few of the seizures that you've been having at home. So that's important. Sometimes we use measures like hyperventilation, photic stimulation, and also sleep deprivation. Keep you up every other night or sometimes on consecutive nights, try to bring out the seizures. Then a neuropsychologist will meet with you while you're in the epilepsy monitoring unit. It's very important that they do a detailed neuropsych testing on you. For surgical evaluation of patients, we want to see what part of the brain their memory is it left, right, verbal, visual memory, both. And also for our patients who have stress-related seizures, try to see whether or not they have any comorbidities, depression, anxiety, things like that. So then the other part is the invasive monitoring. So normally what we do is we put the surface electrodes, that means stickers go on your head, and we try to look at your brain waves. But sometimes that's not very definitive. So if you want to go a step further, with the help of our neurosurgery colleagues, what we'll have to do is crack the brain open, put some electrodes, surface electrodes, depth electrodes in the brain, and then try to get closer to the brain tissue and try to see what part of the brain the seizures are coming from. Let's skip this. I just want to go through this case real quick with you. This is a 22-year-old male patient who had been having seizures since age 13. He had a very varied seizure semiology. So when we sat down with him, he complained of having numbness in his hands and feet, slurred speech, would get cross-eyed, he would get dizzy, tingly, nauseated during speech, drooling, and sometimes lip smacking. Remember we talked about the automatism of the non-purposeful movement of lip smacking, so he exhibited some of those. He was having these seizures once or twice a week. He had a normal neurological exam, no family history, normal MRI scan of the brain done with an epilepsy protocol. Another neurologist saw him, gave him Keppra, but he quit taking Keppra because he said it made him very irritable. Like Dr. Chung said, his wife felt he was a jerk. So he quit taking Keppra. He was not on any seizure medicine. He came to our epilepsy monitoring unit. He came to my office. We said, well, we need to put you in the epilepsy monitoring unit because you could be having seizures, you may not be having seizures. We need to find out before we start to experiment with different medications with you. So here is a clip of what we captured in the epilepsy monitoring unit. So the patient is in the far right corner there, and his brain waves, simultaneous brain waves. So the upper 4 are the upper 8 are the left, the lower 8 are the right side. As you can see, there's some activity starting from the right side of the brain. You can see some rhythmic activity which is coming on the right side of the brain. So there's a technician. Our technician walks in, and he said, "Go ahead, press the event button." You can't hear it, but that's what he tells him. And his hand is right there. His button is right next to him. So now the technician gives him actually the button. Look how he's handing him the button and said, "Go ahead, press the button." He still can't press the button because he's confused, and there's discharge coming from the right side of the brain. And now you can see a little bit of spread going over to the left side as well. And he asks him some questions. He's not able to answer the questions, so he's confused. So I just wanted to show you this, that sometimes patients can have varied seizure semiologies. I mean, they may present with different seizure-like symptoms, and then which does throw some people off. I mean, could or could not be seizures. But what's most important for us as clinicians is to take them seriously, is to bring them into our epilepsy monitoring unit. This gentleman, we put him on Vimpat. He's been seizure-free for the last 9 months. He's tolerating Vimpat, wonderful, 200 milligrams twice a day, hasn't had a seizure. In fact, his clip was actually shown on Channel 3 also about back in June, because he actually had a total car wreck because he had a seizure. He was not on any seizure medication at that time. So now he's been seizure-free and doing well. So the point I'm trying to make here is that when these patients come to you, or when you are sitting with your doctor and you are continuing to have seizures, you want to know exactly why you're having seizures. Where are these seizures coming from? What are my chances of surgical evaluation? Why don't I have a vagus nerve stimulator or other treatment modalities? Why aren't they being offered to me? So you have to be more proactive and sit with your doctors, because it's about you. It's not about the doctors anymore. So in summary, like we talked about, we have to identify patients early on in their illness. If they've tried 2 different anti-seizure medications, we have to start thinking outside the box and see what else can we offer them. They have increased risk of mortality and morbidity that we talked about. All patients should undergo video EEG evaluation to see what part of the brain the seizures are coming from, and see if surgery is an option for them. If surgical option is not available, maybe vagus nerve stimulation or responsive cortical stimulation. Thank you. Do you have a question?
So 11:30, so he won't be able to answer questions because I know he's going to be running. Or do you have time?
Everyone's good.
Oh, okay, perfect.
And as well as the handheld.
Right now, the endocrinologist wants to go to checking for every 3 to 6 months. I mean, if hypothyroidism would then maybe make things worse or that should they be checking on them more often? Left side, left front. And she also has one. When she's 9, basically they want to start checking her 3 to 6 months. For the hypothyroidism to introduce medicine, right? My concern is because she is so young and I've seen such huge difference in her behavior when hormones are off even slightly, that maybe she should be checking more often. Well, yeah, we'll just have a thyroid number because I noticed like big difference, spike in behavior. Yeah, her numbers and when they spike faster and lower. But, you know, they didn't even for about 3 months, so we were like, okay, let's just fix it. But the same thing, probably, like she does, right?
Thank you very much, Dr. Next, we have Dr. Richard Zimmerman. Dr. Zimmerman is a board-certified neurosurgeon affiliated with the Mayo Clinic. He received his medical degree from Boston University and completed his general surgery internship and neurosurgery residency at the Medical College of Virginia, and Commonwealth University. Dr. Zimmerman completed his neurosurgery fellowship at the Barrows Neurological Institute. And at the Mayo Clinic, he is professor of neurology who specializes in epilepsy surgery, stereotactic laser ablation procedures, microneurosurgery, brain tumor and skull-based surgery, and vascular neurosurgery.
Is this his flash drive? He needs his flash drive.
Is this his?
This isn't yours, is it?
No, no,
Okay, could he have a lapel mic?
he's fine.
What do you got?
Well, good morning, and I really want to thank the Epilepsy Foundation of Arizona and Suzanne for inviting me to speak to you. And I think it's wonderful that you're all here to learn more about epilepsy, either for yourself or for your family members. I'm going to try and show some informational material on surgery and some related topics for epilepsy evaluation and management. I know you've had some stuff to eat. I will let you know there are some photographs of surgery that you may or may not like. I will try and warn you in advance so you can prepare yourself and either close your eyes. And the other thing is I will be showing some videos of some seizures as well. And if you've, since you're here for epilepsy, you likely know or have seen or have experienced yourself a seizure. Sometimes it doesn't look very good. It doesn't look make you feel very uncomfortable if you watch it and you know that the public, the people that are unaware of epilepsy, are made uncomfortable by watching someone having a seizure. So just a little advance warning before we start. To be prepared, if you like, I can stop and turn the images off. So I have no significant financial disclosures other than that I have served as a consultant to NeuroPace for financial reimbursement for their responsive neurostimulator device. I serve on other boards, medical advisory boards, and board of directors. One of the disclosure is I'm a surgeon, and therefore I will talk about surgery. Don't think, though, however, that I haven't gotten appreciation for things other than surgery, because it's not always surgery. I will give you the outline here. I do want to talk about surgery, what is established, because that's the basis for where we can go forward and say, okay, what's new relative to what's established. I will talk a little bit about a different type of surgery other than resection, something called neuromodulation, and the difference between that and resective surgery. And then I do also talk about the EMU, its importance to surgical procedures, and the latest advances in the EMU. It would be nice if everybody came to consensus, if all the neurologists and all the neurosurgeons felt the same way and had the same opinion. There are some opinions that differ, but I'm happy to say that everything I've heard so far this morning is agreeable to me, and I think that the physicians that have spoken so far all have the same perspective of how serious epilepsy is and how we can manage it the best possible way. So before we discuss the new surgical procedures, I do want to discuss the old. There's a landmark paper produced by a neurologist, Dr. Sam Weeb, from Canada, many years ago in the journal known as the New England Journal of Medicine. It is one of the highest, most widely recognized medical journals in the world. And a landmark paper was published, but you can see how long ago this was, in 2001. And in 2001, they had completed a study which took 80 patients, randomly divided them into two groups, gave one medication and one surgery. Fairly simple paradigm to figure out what can be done for these patients. Now, the group that they looked at was very specific. This is a group of patients who have temporal lobe epilepsy, and there are other types of epilepsies that are not temporal lobe, so this wouldn't apply to them. But if you have seizures starting your temporal lobe and you were in this study, the findings were very dramatic. Only 1 year after surgery, 58% of the patients who had surgery were seizure-free. At one point in time, you said that that's a cure. They are not having seizures. They still may be on medicines, but no more seizures. In the medical group, only 8% were seizure-free. That's a dramatic difference. Even if they still had seizures, the surgical group had fewer seizures that impacted their awareness, and they had a significantly better quality of life. This is not a close call. This is not a little bit better for surgery. This is a dramatic improvement in surgery. There were patients that had some complications from surgery, whether it be infection, they could have gotten a pneumonia. But one patient in the non-surgical group, in the medical group, died, likely of SUDEP. But it's interesting that in 15 years after this landmark paper came out, to all medical professionals, the New England Journal is for all doctors, not just neurologists, not just neurosurgeons, that we still have a difficult time convincing patients and some doctors to send their patients who have epilepsy for a surgical evaluation. The results are dramatic, and again, this is only for the temporal lobe epilepsy cases, but in general, we still fight to have patients get a good evaluation at a comprehensive epilepsy center because we know the surgery can provide dramatic results and even can result in cure. You can't do better than that. It doesn't make a difference how you look at the data. This is the data from that study. If you want to look at the very significant one-year-out results, patients who had no seizures in the medical group are shown in blue here. This is the amount of patients that had no seizures in the surgical group. If you want to look at the patients that still had bad seizures, greater than 5 seizures that impaired their awareness, a lot of them were in the medical group, almost half of them. In the surgical group, there were very few who, after enrollment in surgery, which is a starting point here, the baseline, and then after surgery, these are the few that still had bad seizures. It's not perfect. It's not a cure for everyone, but these are dramatic results of the benefit of surgery, and specifically surgery for temporal lobe epilepsy. Another way to look at the data is very similar. You can see the difference. These are the percentage who have seizures without impairing awareness, or you can look at patients without any seizures at all. The surgical group does much better than the medical group. So again, I am biased. I'm a surgeon. I recommend surgery a lot. I do surgery a lot. It's not the only option we have for controlling epilepsy, but you can't underestimate the power if surgery can be done. So let me delve into a little more detail about what temporal lobectomy is, or the temporal lobe surgery that I discussed, and is one of the most successful surgeries for epilepsy. If you want to know where the temporal lobe is, it's up from right about where your ear is, and right behind where your eyebrow is, or your supraorbital rim. And you can see this area here. This is the temporal lobe. So when we talk about temporal lobe surgery, the operation is called an anterior temporal lobectomy, anterior meaning the front part. So if you look at the temporal lobe, this pink area is the front half. This is the front of the brain, the front half of the temporal lobe, or thereabouts. If you look from the bottom of the brain, this is the front part of the temporal lobe. This is both right-sided pictures, or right-sided temporal lobes. But you can see when we talk about anterior temporal lobectomy, it's not the whole temporal lobe. It's the front part of the temporal lobe. And one of the unique things about the temporal lobe is the inner part, called the medial or mesial part of the temporal lobe, also needs to be removed for temporal lobe surgery. In that mesial structure, in that inner part of the temporal lobe, is something called the hippocampus. That is one of the most seizurogenic portions of the brain. And in temporal lobe epilepsy, it's commonly very abnormal, even being seen on MRI as an abnormal, shrunken, scarred structure. But when we talk about temporal lobe epilepsy, what is this slide telling you? There's more than one way to what? All right, so there's more than one way to do a temporal lobectomy, to take out the temporal lobe and take out the hippocampus, this little shaded structure in here. So a temporal lobectomy is typically it's a major neurosurgical procedure. There's a fairly large skin incision. There's a large window of bone that's removed, it's replaced. But the temporal lobe, as you can see here, plus the inner structure of the hippocampus, needs to be surgically removed. So do we have to do all that? Is there a simpler way to do that? And sometimes people have tried to do what's called a selective amygdalo-hippocampectomy, or just remove the inner part of the brain and not disturb the rest of the temporal lobe, if this is the most seizurogenic portion of the brain. And it was pursued for a while because there are side effects of removing the temporal lobe, even if it's the side that has your seizures, or your seizures start from. And a lot of it has to do with memory and cognitive function, learning. So if we can minimize some of the downside effects of cutting out the temporal lobe, even though it's a bad part of the temporal lobe, maybe we'll do better and have less of those problems from temporal lobectomy. So this selective hippocampectomy, or amygdalo-hippocampectomy, where you just remove that medial portion of the temporal lobe, doesn't just get to that medial portion of the temporal lobe. You have to go through the normal brain. This is a hole in the surface of the brain to get to that inner part. This is a front view. This is the temporal lobe on the right. This is the temporal lobe on the left. But you can see the trail, the path that the surgeon took to try and remove the inside part of the temporal lobe. Same thing here. This is a postoperative patient. To get to that inner part, though, for lack of a better term, they plowed through the normal brain to get to the bad brain. So maybe this was worth it. Maybe it's a little bit smaller incision. It's a little less discomforting because they don't have to move a muscle. But what are the outcomes? And there have been several studies now looking at all the studies by different centers in a coordinated fashion to try and figure out, is this selective operation better than the standard operation for temporal lobe surgeries? And you can see here by my esteemed colleague, Dr. Weeb, who was really one of the landmark scientists and researchers and clinicians in temporal lobe surgery and epilepsy, they reviewed a meta-analysis, which is a study of all the studies. So they pulled study data together. They tried to make, if we take all the data together, what is it telling us about this procedure? So temporal lobectomy versus the selective. So the ATL, the anterior temporal lobectomy, the conventional operation, gives you a better chance of achieving seizure freedom and freedom from disabling seizures in patients with temporal lobe epilepsy. So they thought that, well, if it's the bad brain, the more brain you took out, the better the patients will do. That's what they found. If you took out less brain, there's a less chance you'll be seizure-free. This is in a neurology journal. In a neurosurgery journal, and you can see these are recent studies, the same thing. If they look at the selective operation versus a standard anterior temporal lobectomy in the management of patients with temporal lobe epilepsy, they found that the selective operation has a reduced odds of being seizure-free. Again, not as good as a standard operation. Now, one of the other thoughts was, as I said before, if you do the selective operation, maybe you can preserve good cognitive function. Maybe the memory will be less impacted. But they found that this selective operation do not have better outcomes with respect to intelligence outcomes, learning, and memory. Again, a neurosurgical journal looking at the selective outcomes, the outcomes from selective surgery versus the standard temporal lobectomy, the outcomes were the same. The neuropsych testing, memory, functioning are again equal. So this new method of surgery, the new approach, trying to take out a selective amount of the temporal lobe, hasn't been shown to be better than the standard operation. Some of the other effects of surgery in the temporal lobe, including losing some vision on the opposite side in the sky, a pie in the sky defect for peripheral vision. There's no difference in that with the selective operations versus the conventional operations. So was this new surgery really beneficial? It really hasn't been shown to be any better. So in addition to the standard temporal lobectomy and the amygdalo-hippocampectomy, that selective operation, is there anything else that really is in the cutting edge of where epilepsy surgery is going? So one thing that makes epilepsy surgery much better these days is what's called neuronavigation, or image-guided surgery, image-guided neurosurgery. And with special markers placed into the skull, frameless systems, frame systems, you can hit an accurate target only millimeters anywhere deep in the brain. And I use this one picture because this is a big MRI picture of the whole brain. There's a tiny speck. The white speck here is a tumor. And you can hit that. You can see this is a bullseye, if you will, getting a probe exactly where you want it, exactly how you want it, anywhere in the brain with image guidance. That ability to get to the inside of the brain with accuracy is really the basis for laser therapy or laser interstitial thermal therapy for temporal lobe epilepsy. So again, we're talking about temporal lobe epilepsy, and this is I need more coffee, Suzanne. Yes, this is a seahorse. What does hippocampus mean? Where did that funny name come? It's not from hippopotamus. This does not look like a hippopotamus. It does look like a seahorse, though. Okay, so the hippocampus in the brain actually has a shape that resembles the seahorse, and that's what the neuropathologist and neuroanatomist call it hippocampus. Anyway, I couldn't show you the laser hitting the seahorse because the people for the ethical treatment of animals would come and take me off the stage. All right. I talked about the stereotactic accuracy that we can do surgery now. When you want to place a probe in the brain, you can get to an accuracy of 0.0 error. That's how accurate surgery has become in the brain. Now, the advantages of putting a laser in the brain comes from its minimally invasive characteristics. This is a patient in actual surgery. You can see there's an incision here. It's about the same size as my fingernail. This is a special fixation device or an anchor that holds the catheter in place inside the skull. There's a catheter sequence that actually cools the laser fiber, and this blue tubing, this is actually a blue fiber optic cable, a small one, that carries the laser impulse into the brain. You can see the hair here is parted more so than shaved. There's a tiny bit of hair that's clipped. But again, the amount of brain surgery necessary is all done from the inside and very little from the outside. This is an MRI of a patient's brain who has temporal lobe seizures from the front view. This is the right temporal lobe, this is the left temporal lobe. This is the hippocampus, and the region of the hippocampus on the normal side. It's much smaller and shrunken on the side where the seizures are coming from, but that dot is that laser fiber. It's placed exactly where you want it, into the center of the hippocampus, to deliver the energy from the laser to damage the hippocampus, and I'll talk about how that works. Again, imaging shows your accurate placement of the laser fiber into the hippocampus. So this is some of the magic. We're talking about laser therapy for treating epilepsy, in this case in the temporal lobe. And what the MRI is delivering is guiding us to give therapy not by producing pictures or images, which is the way that everyone else views MRIs, for pictures. When you do this laser therapy, MR-guided laser therapy, the information from the MRI gives you a temperature map. It actually shows you real-time the temperature inside the brain as the laser heats up and, if you will, cooks the temporal lobe source of the seizures. So this movie shows you what's happening. This is now a picture of the brain in normal temperature. It's 37 degrees, it's gray. As you heat up the laser fiber, the center gets hot. This doesn't burn the tissue per se. The best analogy of how this works is as follows. When you want to cook an egg, and you crack an egg and make a fried egg, there's the clear part of the egg white, that turns from clear to white. That's a change in the protein that causes the properties of the protein to be different. Enzymes are proteins. Enzymes causes or allows cells to live. If you change the shape of the enzyme protein and change its shape, it doesn't work anymore, and cells die. So the example I like to give people about the laser therapy is, if you were to take an egg, you can make the clear turn to white, and that's just heating it enough so it changes the shape of the protein. If you keep cooking it, it goes from white to black as you burn the protein. You don't have to burn the protein of the brain. You just have to heat it enough that you change the shape of the enzymes. When the enzymes don't work, the cells in that part of the brain die. That's how you treat the hippocampus with laser therapy. What this laser does is it makes several spheres of what you'll call damage or cell death in the hippocampus. The way you treat it is you make the first lesion in the front, you pull the catheter back, make another lesion, pull the catheter back, make another lesion, all the time watching the temperature of the brain real time. This is done with the patient completely asleep, so they don't have anything other than sweet dreams during the procedure. This is another movie. It shows you, as opposed to the surgical approach where you have to plow through the temporal lobe, or take out a lot of the temporal lobe in the conventional and selective operations, you're going to see this fiber catheter. You'll watch it here. That little dot is the catheter. It just pushes the fibers of the brain aside until it gets to where it needs to be. Oh, sorry. So you'll see the fiber catheter going through the brain, going underneath the ventricle, and now it's in the hippocampus, hitting the hippocampus, damaging the proteins, and the cells there die. That stops them from causing seizures. What's really interesting is when you do the lesion, or when you kill the hippocampus, if you will, this is what it looks like immediately afterwards. This ring of enhancement is the area of the brain that has been changed and no longer works. In 6 months, though, it shrinks down to nothing. This is the residual of the hippocampus in the brain after laser therapy. Again, how much it seems very impressive up front, but in 6 months, you see what's only left is this empty space where the hippocampus used to be, this small little coagulated bunch of tissue, and that's the old hippocampus. So the laser therapy, or laser interstitial thermal therapy, compared to an open brain operation called a craniotomy, it is really a minimally invasive approach for brain surgery. It's a tiny incision compared to a fairly large incision. There's minimal to no hair cutting or shaving. It's very little discomfort. If you ever had someone or known someone that's had surgery for temporal lobe problems, when you have to move the muscle to come in and get the temporal lobe from the side, that is very uncomfortable after surgery. You also get a big swollen eye. Because you're doing so much less surgery, there's a minimal risk of infection. It's never zero, but it's minimal. The real difference is you're home the next day. After patients have brain surgery, they're going home the next day. That's phenomenal. And it's a big innovation. The benefits also start immediately, because when the hippocampus dies, it dies. It doesn't generate any more seizures. There can still be some irritation of the brain around it, and a couple of seizures can occur in the perioperative period, but the benefit is really immediate. Now, the one thing I'll discuss, though, is the effectiveness of laser ablation is promising, but it has not been studied very long because it's a relatively new therapy. The actual device, the laser, is used in many types of surgery throughout the body, not just the brain. And the way that it's being used now is really undergoing current studies to see how much better it is than the conventional operation at anterior temporal lobectomy, which so far is the gold standard if you have temporal lobe seizures. So I want to talk a little bit about brain mapping. I don't know how many of you know Gary Larson. You must have seen this cartoon before. Well, he's sticking his finger in the part of the brain that controls the leg. That's not how I do it. So how do you figure out where the seizures are coming from? How do you figure out what's the right thing for the patient to do? It was already mentioned by Dr. Sayal about SYSCOM. SYSCOM stands for Subtraction Ictal Spect, co-registered on MRI. What that means is two different studies are blended together. An ictal spect is when you have a seizure, a radio tracer is injected into the bloodstream, it's taken up where the seizure's occurring at. You do the same thing when a patient's not having a seizure. You subtract the two, and the big difference between the two studies is that you have a hot spot only where the seizure starts. You take that image from a nuclear medicine study, you superimpose it on an MRI, and you literally get a map that looks like this that shows you the hot spot that lights up when the seizure starts. The hard thing about this is that the injection has to happen right away after the seizure begins. If you wait too long, the tracer isn't taken up enough. One way of doing mapping. Another way of doing mapping, though, does involve, and I'm sorry, here the graphic photos begin, of implanting grids and surface on the inside the head. It was already mentioned before, you can have surface grids and strips, this matrix of dots, electrodes on the surface of the brain. You can also put them in between the two halves of the brain. You can put maps on the other side of the brain to make sure that there's nothing spreading from side to side. And you can even put tiny little wires into the substance of the brain itself. But the importance of mapping is to figure out where the seizures are starting from, because that's what leads to the option or potential option of resection. Now, this looks very scary. The picture I showed you before shows a lot of brain exposed, a lot of electrodes in the head. And for people who've never seen mapping done, I wanted to just give you an illustration of what mapping is. I won't say it's a really fun experience, but you'll see it's nothing to be afraid of. So there are 3 videos I will show you of people who are being mapped to see where their seizures are coming from and if that area is important. The big deal about mapping is it's twofold. Mapping where the seizure starts, and then mapping to see what that part of the brain does. Okay, because if it's an important part of the brain, you really can't cut it out and you have to go to other options. So this individual, when you do stimulation mapping, 2 things can happen. You can either facilitate an activity, like a motor movement, or you can inhibit or arrest an activity. And I'll show you examples of both. But in this case, the patient is asking to wiggle his hands. You'll see the repetitive opening and closing of his fingers because the seizure seems to be coming from a motor area that controls his hand. And the only way to know that is to stimulate his brain and to see if that changes what he's doing. You might be able to hear him. It's very soft-spoken, but he's supposed to just keep his hands out and not move them at all other than open and close. And watch what happens.
Okay, well, just keep going. I'm going to check.
Yeah, don't rub your face on. You know, you can't control it. Yeah.
Yeah. So basically what happened was he was just supposed to keep his hands still other than open and close them, and they stimulated the part of the brain where the seizures were coming from, and it caused a motor activity that he didn't want to have happen. It wasn't painful, it wasn't scary, it actually was kind of funny. They were all laughing about it. So the brain stimulation can make you do things that you don't necessarily want to do, but that's so important to know so you don't remove that part of the brain and you go to the other surgical options. Very similar situation here, a very exact same situation where the seizures are coming from an area of the brain that seem to be controlling movement of face, mouth, and hand. Tongue is moving side to side, except... So that wasn't a seizure, that was stimulation that actually caused forced movement of the tongue to the left side and head turning to the left side. So again, identification of where the seizures come from is the first step you must take if you're ever thinking about doing surgery for resection. And again, the resection piece is part of the cure. Now, this is a little more complex. This is not now a motor activity, but it seems the seizures are coming from the part of the brain that controls speech and language. This patient is reading from a text, and you'll see what happens is it's hard to hear her because she's so soft-spoken. But watch her face. You can see that she's reading, and she's reading aloud, so her lips are moving. And then at some point she stops, and she can put her lips together, close her mouth, but she can't get the words to come out. You'll see what that looks like.
In addition, the deviations of atmospheric flows toward the people and the air. That's okay.
So all of a sudden, she's reading, and all of a sudden, she can't anymore. She can't speak. So those are areas that are pretty obviously, all the 3 examples I showed you are areas where you can't do surgery to remove the brain, but you have to move to other options. So that segue introduces the topic of neuromodulation. Okay? So what is neuromodulation? We'll cover that. We'll cover 3 different types of stimulation for seizures that are neuromodulation and other prospects. So what is neuromodulation? So neuromodulation is a little different than surgical resection. Resection is cutting of the brain out, or laser ablation is damaging the brain. What modulation offers is for patients who can't have or don't want to have their brain parts removed, even if they're bad and sick brain, they don't want to have it damaged, or you can't, because even though they'd say, yes, cut it out, they wouldn't be able to move the side of their body, they couldn't move their arm or leg, or they couldn't speak anymore. Those are called eloquent areas of brain. The brain parts that control things are not ones that can be removed. For those patients, there is something called neuromodulation. So the concept of neuromodulation can be applied to many parts of the nervous system, whether it be the spinal cord, deep brain stimulation, the brain cortex or the surface of the brain, or even peripheral nerves. Magnetic stimulation can be done through the skin without having to have anything invasive or implanted, and that's under investigation. Another method of neuromodulation is drug delivery, so pumps that can be implanted into the body and deliver medications, whether it be anti-seizure medicines or local medicines to the specific parts of the body or the brain to stop them from having bad effects. I won't cover today these 2, the magnetic stimulation and drug delivery. They're very investigational, but there are some actually devices out in the world now that practicing physicians can use to help modulate epilepsy or modulate the brain activity to stop or control epilepsy better. The one thing I have to say about the neuromodulation, again, it's different than resection, so temporal lobectomy, or cutting out of the brain where the seizures are coming from. It's not curative. Neuromodulation, the technique and the skill and the science behind it helps modulate, control. It does not cure, not yet at least. So again, if you have a seizure focus, and Dr. Sayal mentioned this before, very importantly, if you have a single focus of a seizure onset, part of the brain, partial seizure, if it's not an important area, it should be removed. The surgical importance of that is immense. As you saw from the very beginning of this presentation, if you have temporal lobe epilepsy, surgery to remove that is the best option for you. Now, what if you can't have something removed? Can you have a device implanted? Well, again, the indication for doing something like that is, as I stated before, drug-resistant epilepsy, intractable epilepsy, uncontrolled epilepsy. So you should be tried on several medications, be seen by an expert. You have to have an evaluation where you either have multiple places where the seizure starts, or a seizure that starts in one place, but that place can't be removed, or you have generalized epilepsy. And these are the indications for neuromodulation or the devices. So I'll go through some are familiar, some are less familiar. Vagus nerve stimulation is neuromodulation that's been around the most for epilepsy. It's an adjunct. That means it does not take over the role of medications, but it works with medications. It reduces the frequency of seizures and in adults and adolescents when they're refractory to seizure medications. It helps the medicine do more. It works with the medicine. The best part about neuromodulation is so far there are no drug-drug interactions. It doesn't interfere with what you're already on in terms of medication. Now, there are some side effects. This list is rather long and very complete. The adverse events or side effects of vagus nerve stimulation is relatively small, but when a device does stimulate the vagus nerve, it can cause you to have a tickle in your throat, it can cause hoarseness, it can cause a little uncomfortable sensation. And what it is the vagus nerve is one of the longest nerves in the body. It has connections to many parts outside the brain, but one of the things it does is it goes back up to the brain if you stimulate the nerve. This little yellow tubing here is representative of the nerve. In anatomic diagrams, nerves are usually represented by yellow structures. But what you need to do to put this in is a very simple incision just under the collarbone for the pacemaker-like device that is the vagus nerve stimulator. The wire goes under the skin and goes to the vagus nerve and stimulates the nerve. Now, it's interesting. How it works, it's a bit of a mystery. We can't exactly tell you what modulation is occurring with vagus nerve stimulation that has its effect, that allows it to help control the seizures. The vagus nerve stimulation technically is relatively simple to implant. Different types of surgeons can do it as long as they've been trained and are knowledgeable about the side effects, because the surgery can produce hoarseness that can be permanent if you're not careful. You can have a magnet that helps trigger the device to give you stimulation. The way the vagus nerve stimulator works is it's an intermittent device that turns on and off all the time. You can have extra on times by swiping with a magnet, and you can actually hold the magnet on to the device to turn it off if you need to turn it off for a second. So this graphic here is probably the most important part of the slide. Is it shows you that when it turns on, it doesn't go immediately to full strength, so to speak, but there's a ramp-up phase, then there's the on phase represented by C, and then it tapers off. There's a phase that's H, the off phase, when it's in between the maximum stimulation, and this goes on and off all day long. And that's how it modulates the epilepsy. It can be programmed through a wireless telemetry head that allows the doctors that you work with to slowly turn up the stimulation intensity and frequency so it doesn't cause too much discomfort or no discomfort. The body adapts to that. You don't have a tickle in your throat. It avoids the hoarseness when it cycles on. And one of the interesting things about neuromodulation, and we'll talk about this both with this one and the next device, is that with time, the benefit for patients with epilepsy grows. So you don't have to change the stimulation over time once you get it to a certain effective or maximal therapeutic dose. But over years, the effect of neuromodulation and stimulation with VNS, or vagus nerve stimulation, is improving. Now, it's interesting, the most recent innovation, the innovation from vagus nerve stimulation, includes something that's responsive to the body's response when it has a seizure. So like I said before, the vagus nerve stimulator is going on and off all day long, regardless of whether you're having a seizure or not. If you have an aura, you can turn it on with that swipe of that watch-like magnet. But now they've added a new ability of the vagus nerve stimulator to actually respond. If the patient has a seizure, typically what happens is the heart rate goes up. It gets accelerated. The device can now sense that and give you extra on time, if you will, when the body's heart rate goes up. So it doesn't detect the seizure per se, it detects the body's response to a seizure, and if you have this response with your particular type of epilepsy, you can have extra stimulation from the VNS. Now, I'll talk briefly about deep brain stimulation because in distinction to vagus nerve stimulation, deep brain stimulation has been investigated, but currently in this country, there's no FDA-approved deep brain stimulation. It's still undergoing research, and the reason it came about was because of the deep brain stimulation that's effective for Parkinson's disease, tremor, and dystonia. Those are conditions where deep brain stimulation is effective and is FDA-approved, and we know that neuromodulation, stimulation of certain parts of the brain can stop or mitigate seizures, like we saw for the vagus nerve stimulation. So multiple parts of the brain have been targets to see if we stimulate this part of the brain, will it also control epilepsy, perhaps more directly than just the vagus nerve stimulation. Again, this is an image-guided placement of electrodes. They are monitored in an interesting fashion because when you put electrodes into the brain, if you watch what's happening to those electrodes, the impulses that you can record vary, and that allows you one way of identifying that you're in the right place for deep brain stimulation. It can also be guided by clinical evidence. So when deep brain stimulation is placed in patients who are having tremor, and their hand is shaking, you turn the device on in the right place and the tremors stop. Obviously, radiographically, by taking X-rays or MRIs and CT scans will show you when you're in the right place. Again, I mentioned this, when you place wires into the brain and record from them, the electrical activity of the brain looks differently from different locations in the brain. So it depends if you're in the ventricle or fluid space in the brain, or in one nucleus or a different nucleus, the impulses that we can record are different, and that guides you to placing the electrodes in the right place. Initially, there were 5 patients who had, that was published in this initial study of deep brain stimulation for epilepsy in part of the thalamus, a big sensory relay in the brain. That led to a more cooperative study across multiple academic institutions called the Sante trial, and you can see a lot of institutions, medical institutions that you recognize, the names of here were part of the study, but unfortunately, the evidence that was delivered to the FDA was not enough to convince them that deep brain stimulation procedures is going to be effective enough for them to approve it as a standard therapy. It's still undergoing investigation in both the same part of the thalamus as well as other parts of the brain. And if you look at the medical literature to review what parts of deep brain areas are being stimulated in research for epilepsy, there are multiple areas and multiple studies that are ongoing, but yet it is not approved in this country. There is approval in Europe. So let's talk about responsive stimulation. As I mentioned before, both the vagus nerve stimulator and as well as the deep brain stimulator, those are on-off devices that stimulate all the time. A little bit responsive with the VNS because now it responds to heart rate but not to seizures. The responsive neurostimulation concept is a little different. It really is, I'll go back to the slide, it's focused on detecting the seizure. And when you detect a seizure in the brain, then you give a counter shock or a counter pulse or a depolarizing electrical impulse that actually resets the brain to a normal pattern. It's like a defibrillator for your brain. If you put a cardiac defibrillator, the patient has an arrhythmia, the defibrillator recognizes the arrhythmia, sends an impulse to the heart that gets it back on track. The responsive neurostimulator system, the RNS system from NeuroPace, does something exactly the same, but for the brain. It detects when the brain waves change from a good to a bad pattern, and then sends an impulse to get the pattern back to the good pattern. It's a very specific recommendation when it was approved by the FDA very recently that you have no more than 2 places where the seizures are coming from because you have to put it where the seizures start in order to detect the seizure. And then again, it's very specific indication. You have to have enough seizures to make the surgery risk worth it. So again, the concept of the responsive neurostimulator is that it responds to a specific EEG pattern, like a brain defibrillator. If you localize the seizure onset very well, you have a better chance of getting control. If the seizure onset's not so well known, it's harder to get the RNS to give you a good response. The device is very unique, and where, let's say, the vagus nerve stimulator is placed in the chest and the neck, this has the electrodes placed in the brain for long-term care. The device itself consists of a battery and then the electronics, the circuits of the RNS device. And then you have electrode leads that are where the seizure starts from and where you want to stimulate to stop the seizure. So this is an example of a patient who actually, a large brain surgery to map where the seizures were coming from. It was found that it's near the motor strip where you can't take the brain out. So the responsive neurostimulator was placed with its electrodes in that area. Now, the other aspect that's very unique about responsive neurostimulation is the data that it acquires is immense. The device itself, as I said, just like the cyberonics, can be programmed through a telemetry wand that's not directly connected, but you just hold it over the device. But it goes to a data management system. So you download your data, how often you're having seizures, and it's kept in a database. And you also can be programmed by the epileptologist that follows you, a physician that follows you, into what is used to detect the seizures, because there are many ways to detect seizures, and what is used to stimulate. What's the pattern of stimulation that stops the seizures? It's a very, very robust, very unique system where the data is continually long-term monitored, long-term record keeping, and that characterizes your epilepsy better. So again, similar to the VNS, you can have a magnet that turns it on and off, even when you're not having a seizure or you think you're having an aura and it hasn't picked it up yet. But again, the programming is very unique for the responsive neurostimulation system, and it really is tailored to the individual patient. This is really patient-centered epilepsy care from a neuromodulation standpoint. So again, you have to, this is a left hippocampus, right hippocampus, left hippocampus, right hippocampus. You have to figure out what's the pattern of seizure the individual patient has, fine-tune the seizure detection to match that, and then have stimulation parameters that will stop those seizures. There are many ways. If you look at an EEG, I know you've seen EEGs before, it's a lot of squiggly lines. Well, those squiggly lines are hard to interpret, but they have a fixed way to be measured, either through the line length of the squiggles, the area under the curve of the squiggles, or looking at how many waves and counting the number of waves that you have. There's a large number of ways to try and figure out how to get your responsive neurostimulator to detect your type of seizure and then to know to give you a counterpulse to stop the seizure. It stores the data when it's downloaded into the database. You can have a lot of this put into profiles that actually tell you what your seizure pattern is to get to know it better. If you haven't recognized it, maybe I follow a certain pattern, I need to have the seizure medicine varied to match that, or have the counter pulsations varied to match that. The other interesting thing is how variable the programming can be to stimulate. In this case, it's a positive stimulation given from both electrodes, and it's grounded or centered to the device itself. Or you can have a very localized detection and stimulation pattern where just between these two electrodes is electric current, between these two electrodes is electric current, between these and these. So the stimulation pattern is very programmable and tailored to give the most optimal result. Just like the Cyberonics VNS, the NeuroPace RNS has a lot of different settings from an electrical standpoint. Again, you can get a pattern day to day, hour by hour, or monthly to see what is my pattern of epilepsy to allow you better to live with your epilepsy. Again, this is not a cure. How am I managing my epilepsy in the best way possible for my lifestyle? Again, just like with the VNS responsive stimulator, the VNS, the Cyberonic stimulator, RNS, responsive stimulation, improves with time. Again, a phenomenon that we don't know or can't explain yet, but neuromodulation improves over time even without changing anything else. The interesting thing with responsive neurostimulation, it was studied extensively, including the quality of life index. And these are all the ones that are significantly improved when you have a responsive neurostimulated system for patients that have had epilepsy. Again, there are complications with any surgical procedure, RNS, VNS, and resection. They're relatively low, and again, the risk-benefit ratio for this is significant enough to have the FDA say, yeah, this is worthwhile for patients who have uncontrolled epilepsy. Again, it's not a minimally invasive operation. This is a regular operation with the patient asleep. There's a device that gets implanted into the skull. There are future avenues for new surgeries and new modulation, whether it be the trigeminal nerve, another very large nerve that goes to the brain. There's some work that's being done for seizure prediction. They can't control the seizures, but if you know when one's coming on, you can either take additional medication or adapt your lifestyle to better live with your seizures. So again, neuromodulation works for epilepsy. It's not a cure. It works with your medication. The more we know about the seizure, the better we can localize the seizure, the better the responses will be for neuromodulation. There's a lot of work, again, for seizure prediction. When we started with EEG machines, if you've ever seen an old EEG machine, there were pens filled with ink that would kind of jerk back and forth over a piece of paper. The ability to resolve the degree of information that's happening truly in a seizure is limited by the mechanical limitations of that pen sweeping back and forth. With higher and stronger computing methods and greater computing power and greater microelectrodes, we're just beginning to investigate what happens within a millimeter of tissue, not just a centimeter or an inch of tissue of the brain. So there's a lot of work that's being done to investigate this. I do want to close on one last thing for a comment about epilepsy monitoring units. They are really the place you need to be if you're going to have your epilepsy studied in anticipation of surgery, whether it be ablation, resection, or modulation. These are dedicated units with expertise in their nursing staff and the allied health staff, in the techs that work there. This is significant collaborative and interdisciplinary approach to your medical care, your epilepsy care, that really is emphasized in the quality of the epilepsy monitoring unit that you can go to. And again, there are levels of expertise, 1, 2, 3, 4, and 5, that have been talked about before. This is a high-tech and high-touch area. The nurses and the techs are intimately involved in your care during your stay in the epilepsy monitoring unit. And my last comment is about safety, safety, safety. You're very fortunate. The Epilepsy Foundation of Arizona has one of the national leaders in epilepsy monitoring unit safety, Dr. Noe. She's given talks at our international meetings about the safety, and I want to talk to you about some of the work that she's done with our nurses in our epilepsy unit at Mayo Clinic. I'm going to show you 2 videos, the last 2 videos, and then I'll conclude. These are not easy to watch. You can watch patients have seizures and some are not very pleasant to see. So if you're disturbed by this, please, I'll give you some warning now before we start. One of the very strange things, one of the very difficult things about patients in an epilepsy monitoring unit is going to the bathroom. You want to have the patient observed all the time so we don't miss a seizure, but how do you have privacy when patients need to go to the bathroom? It's a conundrum. It's a big problem. You want to respect the patient's right and privacy, but you can't let them hurt themselves. In the epilepsy monitoring unit, you're there for one reason, to have seizures. What's commonly done, your medications are tapered or stopped. You're very likely to have a seizure. You're really at risk for having harm that seizures can cause. So it's really a problem for people to say, well, I want to stay with you and make sure you don't have a seizure, but I got to give you your privacy. So this is an example, 2 examples in the bathroom of safety in epilepsy monitoring units. The patient's obviously in the bathroom, the nurse is checking on the patient to make sure that the patient's okay. Watch what happens, and then there's a new innovation. What's new in surgery? This is new for EMUs, but it's a fantastic development for safety. Patient's fine so far, finishing toileting. Something just happened. Patient's having a seizure, right? That's the moose alarm, if you haven't heard that before. So what you see here is a harness, a lift. The patient in the epilepsy unit is never outside of this harness, because you'll see this patient, if they were left on their own, even with one person trying to help them, this is not a controlled situation. The lift allows a patient who's having a seizure in an unit to be cared for safely. Sorry. It's a very strong tonic seizure. If there wasn't this assistance to lift the patient, even though there are lots of nurses running to help the patient, it would not be easy to lift this patient and transport them back safely into their bed. One more example, very dramatic. Similar situation. This toileting issue, going to the bathroom is very hard to get rid of. You can't stop that. Okay, so right there. If there wasn't a lift, the patient would be face down, would have slammed to the floor right on their face. We know that the epilepsy monitoring unit is a dangerous location in the sense that we want patients to have seizures, and seizures are not good. But if we're going to investigate and care for those patients, you have to take care of them safely. The use of lifts, as this example and the prior example, really are an immense new safety factor in the world of epilepsy care. And as one person's with them, impossible to transport this person back safely. So in this case, the patient was gently lowered to the floor because the seizure is very violent. They were not able to get them through the doorway safely. But with the lift, they were protected from falling, protected from hitting themselves in the head and against all the surfaces that you would encounter in a bathroom. And again, I can't state how much this has made epilepsy monitoring unit care safer. So with that, I thank you very much, and I hope we have time for some questions. Yes?
So your patients that have, what kind of lifestyle do they have before they go in?
So every kind of lifestyle. The question was, what kind of lifestyle does a patient have? They vary.
I have seizures, right? Just being controlled for the past 8 years. My lifestyle is not like a typical guy. I'm really active. I like adrenaline. I've done things that I shouldn't do. Just that we're playing, Gordon Wolf. But that's the lifestyle that I live. That's what I like. But
It sounds like you have a pretty normal life, though. You have a pretty robust life.
but not the normal life that a normal epilepsy person would live that I've seen.
Well,
Typically, when I go to the doctor, I see people look like zombies.
so I'm just trying. So help me understand. What's your question?
The question is, what kind of lifestyles do the patients that you have when they go in and when they come out? I mean, are they doing the same thing? Are they doing something different?
It's very varied. So some patients with epilepsy are controlled by medications. They have normal lifestyles. Some patients are difficult to control with epilepsy, and their lifestyle changes, whether their seizures are good or not. They have bad days or good days. Some patients are very impacted by their epilepsy, so they can't work, they can't drive, they can't date, they can't have a job. So it varies. There's no one profile that fits a patient with epilepsy. Patients with epilepsy like yourself have good lives, good quality of life, normal life. A lot of patients, I would say probably the majority who have epilepsy, don't quite have the same life that you do. Any questions? Yes, sir. Not last year. It's only about 25 years ago. It's possible. That's possible. I haven't been a BNI for a while. Yes, sir.
Response to neurostimulations in 2 areas of the brain.
So it's very interesting. So the FDA, in their ability to try and make it safe for patients, but not give carte blanche to the people who want to put devices in brains, has set very specific limits. Because putting electrodes in a brain is not a small operation, once you're there, they said, you can actually put in 4 different strips of electrodes, or 4 different sets of electrodes. The device itself only allows 2 at a time to be connected, but if you have a general area of where the patient's seizures are coming from, you can put in 4 different sets of electrodes, connect 2 of them, and if that doesn't help the patient enough, if it's not optimal, you can actually, during one of the battery changes or during another procedure, surgical procedure, you can have the electrodes that are connected changed to potentially better map and better match the patient's seizure type. So it's usually 4 electrodes are placed in the brain. Unless you have a really good knowledge of where they're coming from, you don't have to put in 4. You can only connect 2 at one time, but it does have some ability to be flexible.
Generalized seizure situation, is that optimal?
Correct. So responsive neurostimulation, the RNS device from NeuroPace, is not meant to be used for generalized epilepsy. It's really a detection when you have a focal or partial onset seizure. You place the electrodes in that area to both detect and then stop the seizure before it progresses.
Okay. We need to cut the questions just because we're so behind.
I'm sorry.
No, that's okay. Thank you, Doctor.
Thank you very much.
Thank you, Suzanne. Can you guys hear me okay? Is this, okay, perfect. So I want to thank the Epilepsy Foundation for inviting me to talk about this very important, but really actually very difficult topic for me. You know, when I...
Do you want me to, I could do the
No, I could do this, yeah, thank you. So this was a very challenging topic. I mean, as you can imagine, what does living well mean for those who have epilepsy? That could mean driving, that could mean being able to do, the skydiving I heard someone say earlier, doing some of these things. So this was a very challenging kind of topic. But when I sat down, I actually looked at, what really defines sort of and impacts quality of life. And I asked actually some of the neurology residents that work with me, and most of them said, well, probably if they're seizure-free. And that's actually part of the answer, but that's not really everything. Being seizure-free isn't the only thing that really, I think, and most of you can probably attest to that as well. So I did what most of us do, which is go to Google and actually kind of looked at, what are some patient perspectives. And I found some interesting memes, basically, kind of what patients with people with epilepsy think about what impacts their quality of life. And so some of these things, feeling alone and living with a disorder that most people don't understand, having fears actually about living alone or being by yourself, and then coming to after a seizure with people in a room with people staring at you, not knowing what had happened and not understanding what's going on. Also, not being permitted to drive or being afraid to drive. So definitely I have had that discussion with, yes, you're fine to drive, but having that fear, well, what if I have a seizure when I finally do start to drive? And then certainly when we get to the medication aspect of things, I put a little joke in here, but it's very important, even if you do have side effects, how does that impact your quality of life? So epilepsy really is a disorder that's characterized by loss of control. As I said, seizures can really happen at any time or with little warning. And that really has impact. For me, I treat adults, we're adults here. The pediatric side, this is probably not much of a concern, but certainly driving is independence for a lot of people. So that does impact the independence. And how does that impact your job? What do you do for a living? Do you have to drive for a living? And so definitely some changes there if you do have epilepsy. And we have found that there are really lower rates of, in general, social interaction, but marriage and relationships, because again, people don't understand the condition. And so it leads to people with epilepsy being more isolated. So I thought I would talk about kind of 3 big areas with questions that I get in the clinic about, and when I talk to my patients and say, well, what do you want to do? And these are the big areas. What can I do? And, how am I going to feel with these medicines and with doing other things? So Talk a little bit about safety, particularly things that what activities we do and how we discuss modifications. A little bit about driving and some of the driving laws. Talk about health, and the reason why I actually picked pregnancy and bone health, those are probably the two big ones that I get asked a lot in the clinic. I have a lot of young women. Can I get pregnant? What are some of the misconceptions about being pregnant with epilepsy? And then also later on, how are these medications or how is epilepsy going to affect my bone health? Certainly those are topics that are actually probably an hour talk on their own, but I'll just touch on those a little bit. And then of course, something that I think is totally under-recognized and not talked about as much is the mood and the emotional aspect of epilepsy. So when it comes to safety, really the goal is a balance, and it's a balance between what are the risks and what are the restrictions that you have to discuss. And so just to talk about some activities here in Arizona, we have fantastic weather, lots of outdoor activities. People like to be out doing things. What are the things that I counsel people about? And so swimming. Can I go swimming? No, yes, absolutely. There are just some safety things that we do recommend. And so of course, life vests, even in a swimming pool, use of life vests, and never swimming alone. And I think that's actually the most important thing is it's not just swimming with someone else, but swimming with someone who is strong enough to get you out if you run into a problem. And so, so definitely those are things that that you can still do just with some modifications. Bicycling is another big one. And so we have two pictures here of people enjoying bicycling, and then there's clearly a problem with one of these. So no helmets. So as a neurologist, I actually probably counsel everyone to use a helmet when they're on a bicycle, but particularly if you have epilepsy, again, if you have a seizure and it's a surprise, you're gonna fall off, and it definitely can help prevent head injuries. The bottom panel, we have, Peter Griffin is not always, doesn't always make good decisions, but he gives this 2 thumbs up as well. So basically, just use helmets, but certainly I tell my patients it's safe to ride a bike. And then we have other sports, so I kind of put it there, volleyball, basketball, baseball, softball, all of these other things, all safe to do using the recommended safety equipment for the sport. So a little bit about driving, and I don't know if this projects well. I borrowed this from the US Department of Health and Human Services, and this is actually a big question for my patients. Okay, I can't drive, I drive to work, I drive an hour to work every day. We don't live in New York that has a fantastic public transportation system, so this is a big problem. So as you can see on the color-coded map, here we are. We're 3 months no driving after a seizure. Now we're a non-reporting state, but we do ask that, that if you have a seizure, you report yourself. But you can see some other states here like Oklahoma and Mississippi, they are 12 months no driving. Most of the states in pink are kind of flexible, and it sort of depends upon what the circumstances are around the seizure. But a lot of places really are much more strict with driving rules than we are here. And so, so I wanted to talk specifically about 2 jobs because I actually had a couple of patients who came to me and said, I've had some seizures, and what does this mean for my livelihood? So truck drivers, these are 2 big ones. So most of the time, and I think we're going to talk a little bit about later in the afternoon, a little bit about employment, but most of the time, most jobs are safe, and you can continue doing it, perhaps with some restrictions, but there are a few where really it can definitely impact. Truck driving. So the US Department of Transportation actually prohibits anyone with a diagnosis of epilepsy from driving, and this is permanent. So even if we get someone under good seizure control, they can no longer drive. Now, I do have one patient who was a truck driver, developed epilepsy, and then had to really change kind of his whole perspective in his career. And that really, he became very depressed about that because he'd been doing that for so long, he didn't know what else to kind of do. At this point, it's really for interstate, so if you're driving from state to state, but actually some states are adopting it within their state as well. So, so definitely a change there. And of course, pilots. So even to get a pilot's license, you have to be seen by an FAA physician. And they generally do not even issue it if you have a history of epilepsy or a history of anything where you've lost consciousness. So even unexplained passing out episodes. That being said, there are some exceptions. If you're seizure-free for more than 10 years without medications, then you can fly again. Again, if you're a 50-year-old person who then is having seizures and is now seizure-free, they don't let you fly past a certain age anyway. So again, that sort of does change their employability at that point. So I'm going to segue a little bit into health. And as I said, I'm going to focus on two of the big questions that I get in clinic. So for those of you that are men, and this doesn't apply to in terms of pregnancy, I apologize ahead of time. But I have a lot of women, and this is a big part of the counseling. And even at this point, I actually get a lot of women in my clinic who have stopped the seizure medications because they've heard bad things about it during pregnancy and are having lots more seizures and want to know, what to do, which is not the right way to go. So actually more than 1 million women in the U.S. are actually of childbearing potential. 1 million women with epilepsy in the U.S. are of childbearing potential. And the use of anti-epileptic medications is not really limited to epilepsy at this point. So we use it for migraines, chronic pain. And so really the exposure is likely quite a bit higher than this. So you can see it's a lot of people that this impacts. And when we look at the different stages, so before pregnancy, I actually have this discussion with any woman who could possibly get pregnant. Now, the 19-year-olds usually I'm not even thinking about having kids, but that's the point. You really want to have this discussion ahead of time. You want to plan the pregnancy. That being said, about half of all the pregnancies in the U.S. are unplanned. And the most common thing that I get is a phone call saying, I just found out I'm 10 weeks pregnant. Now what do we do? So doesn't mean that all is lost and we can't do things at that point. But certainly, we like to plan and discuss this ahead of time. Because the main reason is we really want to get seizures under the best control that they can be before pregnancy. And from the data that we have at this point, actually, we know that if you are at least 9 months seizure-free before you get pregnant, that increases your chance above 80% that you'll remain seizure-free during pregnancy. So it's really, it really is important for us to get you to the best control that we can. And also to the lowest dose of medications and the least number of medications possible. So, we know some of the risks go up with being on several medications. So if we can get you down to one, or at least on a stable regimen at low doses, that's always preferable. And then certainly the usual prenatal vitamins and folic acid. So there's no consensus about kind of how much folic acid to take, but typically I do recommend 1 to 4 milligrams a day, in addition to what comes in the prenatal vitamin. So during pregnancy, this is a kind of a busy slide, but basically about 20 to 33% of women will actually have worsening of their seizures. About 7 to 25%, so a big range there, have a decrease, and 50 to 83% have no change. So what that really says is about half really don't have much of a change, and about a quarter get worse and a quarter get better. And so, so you can see how really trying to get under that good control ahead of time, we can kind of optimize what happens during the pregnancy. And the other big question is, well, I don't want to be on this medicine. I've heard bad things about being on this medication during pregnancy. And so, the main thing is, what are the risks of being on the medication? And the biggest thing that comes up is with the malformations. And so cleft lip, cleft palate, and cardiac defects are the 3 big ones. And in the general population, so all women, that risk is about 1 to 3%. In women with epilepsy, that doubles to about 4 to 6%. And certainly that you're on the higher end of that spectrum if you're on more than one medication. Now, what we do know is that with valproic acid or Depakote, that risk is the highest. It's about 9 to 10%. That being said, if you look at it the opposite way, even if you were on Depakote, you have about a 90% chance or higher of having a normal, healthy pregnancy. So doesn't mean that you can't be on it, but definitely, personally, and probably any of the other clinicians in the room, this is not, I would not put one of my women who plans to get pregnant or who could potentially get pregnant on Depakote. Excuse me. So then we get back to, well, what do we do to prevent all that? And as you'll see, this is the same slide I put up before. So planning. Have that discussion with your doctor ahead of time as best you can, so that even if you do have that unplanned pregnancy, you've already maybe been working on it, maybe you've already talked about folic acid, maybe you've already been doing well with your seizures, but it really is a discussion that needs to be had before you get pregnant. So the other big question, well, if I'm on these forever, what does this do to me long term? And I think the biggest concern is always fractures and bone health. And so it is true that people with epilepsy, so this applies to men and women, have about a 2 to 6-fold increase in fractures compared to the general population. Now, this is related to both to the seizure medications themselves and also to seizures. So if you fall and you can get compression fractures or things like that. And that bone mineral density measurements have shown about a 38 to 60%, 38 to 60% of people with epilepsy have osteopenia, which is low or low bone density, or osteoporosis. The main medications at this point that we know that are associated with this, I've put a list up here. We have phenytoin or Dilantin, carbamazepine, Tegretol or Carbatrol is the brand name, phenobarbital, primidone, and then valproic acid or valproate or Depakote. And so these are some of the older medications. And so some of the newer medications, don't really have this association, but that's still kind of something that we're collecting. One of the medications that Dr. Chung spoke about this morning, Aptium, is a new medication. We're not really sure if it's going to have effect on bone density, but since it's related to carbamazepine, that is always a possibility. So some of the newer ones, we still think about it, but typically it's these older medications that it's a bigger concern with. And so how do we treat this and how do we monitor this? And we do recommend bone mineral density testing at least after 5 years. I probably go a little sooner than that, maybe after 2 to 3 years of being on the medication. But if it's a postmenopausal woman, either before treatment or when you're instituting it, so you can get that baseline, because that's when we know the osteoporosis risk goes up anyway. So then we can actually speed up that process by putting on one of these medications. And then typically you do kind of monitoring every year. I also do vitamin D testing. You'd be surprised that probably the vast majority of people in Arizona are vitamin D deficient. You think you're outside a lot, but I think it's because most of us avoid being out in the sun. And that's for everybody. So, but it's very important, and I check that in people with epilepsy, because then it does determine doing some of the supplementation with calcium. And then you kind of decide what you need to do with that. And then, of course, regular exercise. So particularly weight-bearing exercises. You don't have to go and lift lots of weights, but walking, getting out, doing some of those things really is actually good for bone density. So now I'm going to segue in a little bit to mood and emotions. And I will tell you, this is probably the biggest not talked about topic that goes along with epilepsy. I mean, it's very under-recognized. I think that very often we might get caught up in talking about seizure control, seizure medicines, and really the mood and emotion aspect of things gets kind of pushed off to the side. And so before I get into it, I wanted to throw in a little historical piece here about why some of that is. And so Hippocrates, who some of you may know, is considered sort of the father of medicine, wrote lots of texts on various conditions, but wrote a text in 400 BC, so a long time ago, on epilepsy. And before that, some of the historical and cultural perspectives really were that epilepsy was a condition that was either magical or from God or a result of evil spirits, but really was sort of that good and bad, good and evil. And it was not until this that really it was thought of as a natural condition like other things that they had recognized at that time. And so he says here that epilepsy has a natural cause and its supposed divine origin is due to men's inexperience and to their wonder at its peculiar character. Now, that was 400 BC, and I think that that's probably still true now. There's still a lot of just that mystery surrounding it, a lot of fear. People see it, seizures are scary, and so what happens is that a lot of people with epilepsy have stigma or the social kind of negativity that goes along with it. And I bring that up because when we look at sort of the impact of epilepsy and all of the things, it's not just how many seizures someone is having, and that affects their mood and their behavior and their quality of life. It really is a lot of other things. And so this was from a paper and actually in the 80s that looked at what we call up here the psychosocial variables. So these are things like how well has the person with epilepsy adjusted to the diagnosis? What support systems do they have at home? What is their social situation in general? And then we have down here medications. So what medications are they on? How many are they taking? What are the side effects of it? Are they side effects that worsen mood, don't have much different mood, cause other problems that are just unpleasant in addition to it? As Dr. Chung said earlier, with bromides, you know, having skin breakdown is also not pleasant. So where do you draw that line with having seizures versus having the other side effects? And then also we have epilepsy features. So how long has someone had epilepsy? How many seizures do they have? What other problems going along with the epilepsy do they have? And so it's kind of these three categories that not equally, and it's different for each patient, how much really plays into it. For example, someone who has really good social support, maybe these are this category isn't as much, but it's these three main categories that really goes into the quality of life and how what we call the mood and the emotional aspect of epilepsy. And I just put this up here because there are, and again, as Dr. Chung mentioned, you know, the epilepsy itself, the most common area is the temporal lobe in adults. And that is an area that goes along with mood and emotion. So there is something from the biochemical aspect that it definitely leads to having an increase in these, but also having a chronic condition that people don't understand or that, you know, that you've had a lot of negativity associated with or whatever really leads to having a higher proportion of of these moods. So in terms of depression, people with epilepsy have about an 11 to 50%, or it's about 11 to 50% of people with epilepsy have depression, whereas in the general population, about 5 to 17%. With anxiety disorders, that difference goes up quite a bit. When you see in people with epilepsy, about 15 to 25% versus 5 to 7% in the general population. And you'll notice with panic disorder, up to 21% as opposed to about 3%. So 7 times the amount in the general population. And then, of course, attention deficit disorder is also higher in the epilepsy population, but I'm not going to talk about that as much. And so I've mentioned a little bit why these symptoms are underreported, but the main thing is that there is a fear of being labeled crazy. So going back to that, there's that stigma that goes along with epilepsy, and then the stigma that goes along with mental health in our country and depression and anxiety. And so put those two together, it's like, okay, well, I have epilepsy, we'll just talk about that. I don't want them to think I'm crazy on top of it. And then there's the belief that these symptoms are just a part of epilepsy and that I just have to deal with it I just need to get my seizures under control. And to some degree, as I mentioned, some of the chemical features of it, that's true, but certainly there are things that we can do to treat that, so it's not just a part of your condition. And then, of course, it's not asked about. So thinking about some of the interactions that you may have had if you have epilepsy with your health provider, or if someone you know has, talking about, okay, I put you on this medication, how many seizures, how are the seizures going? And then there you go, that's the end of your visit. And not really asking, how's the mood? Anything going on? How's the anxiety? And also not bringing it up, and so then it doesn't get addressed. Now, going back to that question about, that I told you about, you know, what goes into quality of life? Is it seizure freedom? And that was kind of the perception from a lot of the residents that I asked, was that, well, if it's seizure free, then that's probably what it is. But this was a survey that was published initially in 1997 and then republished again actually in 2002, and looking at the impact of epilepsy and based on treatment and seizure frequency. It's a very busy slide, so I'll point out just a couple of things. But basically, they asked people with epilepsy, how did they feel that their epilepsy affected these following things? So their relationship with their spouse or their partner, social life, their activities, ability to work, and then not only that, ability to work in doing what they wanted to do. Their health overall, relationship with friends, feelings about themselves, and then how they looked toward the future. And also just how did they live? And so over here, kind of to the far right, these are the people that had at least one monthly seizure. Now those are very frequent seizures. You can see those numbers. 40 to 60% of people said, yeah, I think epilepsy really negatively impacts these things. But if you even go to people who'd been seizure-free for 1 year, a significant percentage, in some case, a third of people still thought that this was really negatively impacting their life. And so it's important for us, I think, as providers, but also to have that discussion when you're following up and say, I'm seizure-free, great, we'll see you next year. But how are other things going in your life, and how's the mood, and how are other things? So a few kind of, you know, some of this you guys have probably already heard in talking to your physician, so I expect that some of you this wasn't all new, but certainly some tips that I will have a discussion with the patient about living well and hopefully keeping seizures down and allowing you to do the activities that you'd like to do. So get plenty of sleep. Easier said than done for a lot of people if you have small kids, if you have a busy job. But certainly we know that sleep deprivation does lead to, can be a trigger for seizures. Avoid alcohol. I'm not as strict on this. A drink at a wedding or a social occasion is usually okay, depending on how sensitive your seizures are. But certainly, it's really if you feel drunk or if you're drinking several drinks, that we do recommend not doing that. But you know, it's case-by-case basis. But in general, we know that this can be a trigger. And very often, with our college students, these two go together, right? So they're up all night drinking and hanging out, and then you have a seizure. So you really have to kind of weigh both of those things. And as I was mentioning, really talk openly with your healthcare provider. If they don't bring up something you want to talk about, bring it up. Say, you know, yeah, my seizures are great, but I still lost my job, or my job I'm worried I can't do what I want to do. I have a patient who's doing really well now with her seizures. She wants to go back to college. That's her quality of life. I just want to go take one class. And so you really have to have that open discussion with your provider about what you'd like to do and how best to get you to that point. And stay active. So another misconception, I can't do any of these things. Now, I do typically kind of recommend against things like skydiving and all of those things, I mean, from an epilepsy standpoint. But certainly, go out and do the sports that you'd like to do. Go out and ride bikes, go hiking, do all of those things. Just be safe and exercise sort of, you know, the safety rules that we talked about. And find support. So I was talking to someone in the audience before the talk, and it was, well, I've been seizure-free, I'm doing well, but now I have some other things. And so really make sure that you have the social support and seek help with either counseling or with support groups to talk to other people who are in similar situations. And that's really, I think, really beneficial, and kind of tell you, this is where I was with my epilepsy, this is where you can be. And I think that goes a long way, rather than me telling you this is how to do things, and I'm not the one walking in your shoes. So the last thing I actually wanted to, kind of not really about living well, but you know, I think one of the things about you know, Parkinson's disease, for example, everyone knows Michael J. Fox and Muhammad Ali are the faces of Parkinson's disease. And I think, you know, does anybody know a celebrity who has epilepsy? Can anyone name a celebrity who has? Prince? Jack Black. Well, I'm sorry, what was the last one? Exactly. So, but that's the thing. Everyone's looking around. I saw a lot of, I don't know, this. So it still highlights to us, you know, that people don't talk about it. But it also lets you know, and I'm going to show you kind of a couple of examples, that you really can go out and do and accomplish a lot with epilepsy. So, oops, I went backwards there. So no one will recognize this person, obviously, but this is Shonda Gunn. She's actually a U.S. ice hockey player, won a bronze medal in the Olympics, and she has epilepsy. So she's actually an advocate for epilepsy. Nobody's probably heard of her. Prince, someone named Prince, had epilepsy as well. Neil Young, so very prolific musicians. Danny Glover, an actor. Agent Smith, or yeah, so also has epilepsy. Amy Lee, she's the lead singer for a band called Evanescence. I don't know if anybody knows who it is, but she's an excellent singer. And then, of course, most recently, our friend Lil Wayne, who had seizures, and this was all over probably a couple years ago, all over the news, and then actually came out and said, yeah, I have epilepsy. This is something I've been struggling with my whole life. But it really is something that I think you can go out and accomplish a lot of things. I don't know if Lil Wayne should be your role model, but, you know, but you can really accomplish the things that you want to do. But it also highlights, as I was mentioning, you know, really where is that sort of celebrity face on epilepsy? And I think we still need to work on some of those, you know, the negative stereotypes associated with it to make it more comfortable for someone to come out. So that's all I have. Thank you. If there are any questions. Sure.
You mentioned about the people with depression, the 11 to 50%, anxiety. Is that people just with epileptics, or people on certain medications, or was that just widespread without the expert?
So that was actually just people with epilepsy. So they didn't separate out kind of the medications. But that's a good question. So, you know, in terms of how do the medications both help that and probably make that worse? Is that kind of?
Yeah, I was just wondering, I mean, that's why I was wondering if they actually broke it up. But possibly that would be hard to go ahead and determine, because you have to go ahead and figure out, okay, these people took this kind of medication to be able to identify their depression. And I was just wondering if they knew if there was a difference between.
So this didn't particularly look at that. It was sort of all comers, but I will tell you there probably is a difference. I mean, there are some medications that we know can definitely make mood a little bit worse, like Keppra or levetiracetam. It's a very good medication, but in some people it actually does make them much more irritable, versus some things like divalproex or Depakote can be mood stabilizing, but I've had some people get irritable on it. As a general rule, all of these medications can have actually an FDA black box warning that they can worsen depression and increase suicidality. But in practice, it's not true across the class. So really, but to answer specifically, this just kind of was all comers on that one. No, so actually the bone health problem, I should have been a little more clear. It's men and women actually with epilepsy. So that's a good question, but yeah, it impacts both.
One of the questions I have is for someone that has epilepsy and they don't have a good support system, depressive mode, and dealing with the things that we can, what would you suggest the next step of recommendation you would have for that person that doesn't have support, that is looking for it, and is not getting it at home? What would you recommend?
So we have run into that a couple of times, and I would actually, I talked to people about joining support groups, because if you're not getting that at home, at least attempting to find other people who are in similar situations. So support groups. I also really do recommend counseling. Now, as the mental health system here in Arizona is a bit of a challenge to navigate, and in general for any reason, but I always advise, maybe we need to send you to counseling or to, not just psychiatry, but psychology and working on some of those things as well. So it's a challenge because, especially if this is someone who you're living at home with and you're surrounded by them every day and I see you every couple of months or you're seeing a counselor, it really is a challenge. But I definitely do encourage kind of go out and see these groups that have people that are in similar situations. Any other questions? Okay, thank you.
She received a PhD in clinical psychology from the University of California, Berkeley, and she completed a clinical internship and postdoctorate training at Northern California Veterans Administration
Once
at the University of California, Davis,
she turned green.
Department of Psychology. She joined
Oh, it
Arizona
seems I'm going
University
better.
cultural and biological forces that shape emotional responses. Specific to our conference, research that the emotional system breaks down in patients with neurological dysfunction such as seizure disorders. Areas of teaching include introductory psychology, abnormal psychology, psychosocial issues and clinical psychology, physiological psychology, and she supervises undergraduate research and clinical practical experience.
Thank you. I'm good, I can use this. That's fine. Hi, thank you for having me and for all of your hard work. This is quite an event. It's my first time here, but we've advertised our research on the Epilepsy Foundation website, and it's been a helpful, great community. How many people are familiar already with psychogenic non-epileptic seizures? Okay, quite a few of you. And all the talks thus far really paved the way for what I'm going to talk about. So psychogenic non-epileptic seizures, and we'll break down these terms, are not epilepsy. It's very confusing. I'll talk about why that is as well. They're behaviorally similar to epilepsy, and one colleague writes about it in a paper as showing a superficial resemblance. So you're looking at someone, you think they're having an epileptic seizure, but they are not. And the reason they're not is because if you bring them in for the video EEG monitoring that we've heard about, their EEG is normal. So it's this huge conundrum. I first got into this work because I study emotion, and I had a neurologist colleague say, well, you study emotion, can you help us with this situation where these people are having seizure-like behaviors, but their EEG is normal, so what's going on? And the terminology is a big deal because if you call these non-epileptic seizures, you still have the term seizure in there, and seizure implies that you're having a certain type of EEG activity, which you're not. And so instead, they've been called events or behaviors or spells, attacks, and there are a lot of terms that are quite derogatory. I've heard this called hysterical epilepsy, hysterical seizures. Now the term stress seizures is used more commonly, which can be confusing because people say, well, I'm relaxing and I have these events, so how could they be stress-induced? Pseudo seizures, which the program says, but that also can be a term that is invalidating for some people because it implies that what you're experiencing is not real. And so I'll make the case for how it is real, it's just different from epilepsy. So I use the term psychogenic non-epileptic seizures. Psychogenic meaning more psychologically driven, not epileptic. And then terms like non-epileptic attacks are also becoming quite popular. So these are more common than you'd think. And again, we heard earlier about treatment refractory epilepsy. So people who have epilepsy, but they're not responding to medication. And so about 10 to 20% of people who are referred to epilepsy centers, some places would give you figures of 50%, 70% of patients are actually having non-epileptic seizures. And so you often find out about these because people are seeming to have a seizure. They're on different medications. It's not working. It's not working. You bring them in for the video EEG monitoring, and lo and behold, the EEG is normal. And so once you have the intractable or the types of seizures we heard about earlier that are not responding to drugs, you might suspect psychogenic seizures are going on. And what's interesting is we really don't know at its core what causes these, but practitioners will tell patients that it's due to stress, past abuse or trauma, anxiety, depression. So someone comes in thinking they're having epilepsy, and it's like, oh, good news, you don't have seizures, you don't have epilepsy, but, you know, we don't know what's causing these, and stress, anxiety is sort of the catch-all. And in clinical terms, this could be referred to as a conversion disorder or a dissociative disorder. So again, I'm a clinical psychologist, so that would be how these are categorized. And again, I'll kind of explain why. So there are many sources of confusion with PNES because you can have epilepsy or PNES or both. So you may be someone with epilepsy, and at some point, you end up with PNES, or sometimes vice versa. They think you have PNES and you don't, but that I think is less often the case. The important thing is that epilepsy treatments do not work. The anti-epileptic drugs do not work. They do not help for this particular condition. And so it's easy to think, oh, it's not epilepsy, so people are just having fake seizures. They're just faking their symptoms. And that's actually not true. People are still having these involuntary muscle convulsions or different movements, and they're not under their conscious control. They're not aware of their surroundings, but their EEG is normal. Yeah.
Press it once. It's on green.
These are primarily adult statistics, but it does occur in children as well. And that's a whole other complication too, because with kids and the developing brain, it can be hard to know. But PNES definitely exists in kids, and you see it came to the attention of the media. There were whole groups of teenage girls who were having this condition. Yeah. So one piece of good news, in some of our data, we asked people, what do you think the cause is for your seizures? And the people with, or seizure-like symptoms, and the people with PNES that said, we don't know, it's unknown, they actually showed better emotion regulation and better coping, and it's hard to know which comes first. And at first we thought, well, maybe this is like ignorance is bliss. Oh, I don't know what's causing these and you're okay. But I think it's more of an acceptance, like I'm having this, I know it's not epilepsy, so I know not to take anti-epileptic drugs. I know not to keep banging my head against the wall, getting the monitoring in the neurology office. But we don't know exactly the biological basis yet. And some other good news, I mean, this seems pretty loud, so people, I have to do the projector thing anyway, so we're good. So the good news is studies of emotion are providing clues, and again, it's neat to hear that emotion is really understudied in epilepsy, because that's what I study, so I'm like, oh, I'm sure everyone studies emotion in epilepsy, but now I know not so much, so this is good that we're doing this work. And I found that the people experiencing symptoms, whether it's epilepsy or NES, really are the people who are generating the research questions and a lot of the answers. So in our research, we've really come to rely on the people experiencing these symptoms to help us know where to go next. So this is a picture of our library building. This is at Arizona State University's West Campus. We're over here by the Tempe campus right now, but our West Campus is over in Glendale off the 17. And what we do in our lab over there is we study emotion. And So I say that people have emotions all the time. Like right now, you might be interested or bored, and you could argue things like sleepy is an emotional state, but you might be happy or angry or sad, and your emotions can change suddenly based on something I say or a thought that pops into your head. If there was a fire drill all of a sudden, you would have a different emotional response. And when an emotion happens, there are changes both in your experience, you know, oh, I feel angry right now, if you're aware of it, and in your body, and then in your behavior. But, you know, we don't show what we're feeling all the time, or even most of the time. There are all sorts of regulatory processes that happen. And so you can regulate what you're feeling or change, modify what you're feeling based on the situations you put yourself in. And then once you're feeling an emotion, so if you get a gift and it's disappointing, even little kids start to know that they should say, oh, thank you very much, and just try to keep it to themselves that they're really upset. So in our lab, we study not just emotion, but how you're regulating your emotions. And some people would argue you can't even separate the two. So again, as we've heard about today, there are many studies that suggest that if you have epilepsy, and especially temporal lobe epilepsy, we heard a good case for it earlier, there's something different in the emotional processing. And again, if you have temporal lobe scarring, then definitely that can create alterations in how you process emotions. And then in PNES, I think of it as kind of the reverse, where you're having what looks like a neurological symptom, but it isn't, and it's thought that it's due to emotions in some way. So this cartoon, my caption is, we're not always aware of our emotions. The job candidate is saying, yes, I think I have good people skills. What kind of idiot question is that? So we're not always aware of our emotions, and I think typically we're not. And so this is a kind of complex looking diagram, but this is from one of my articles that is basically saying we have all these thoughts, memories, images, sensations. We have all the kinds of emotional processes that I talked about, physiological, regulatory, and then our outputs, so your mood, your physiology, how you feel when you get up in the morning, throughout the day, all these things can be related to your emotions, and there are different levels of consciousness or awareness. So sometimes you may be really aware of what's bothering you, and other times you're like, I just have this feeling, but I don't know what's going on. And it can be easier to be aware of what you're feeling in the moment, but harder to think about it in terms of, oh, my heart is racing, something like that. So what's interesting is, as I mentioned, psychogenic seizures are thought to be, I was thinking of the slide from the previous talk, people are afraid of being labeled crazy. Well, this is like 1,000 times for people with non-epileptic seizures because they're having these seizure-like symptoms with no identifiable medical cause. And so basically, they feel like they're crazy because there has to be some kind of emotional thing causing these, but no one knows what it is. So I'm here to tell you there are biological patterns that we see in people with these psychogenic seizures that we don't necessarily see in people without them, but we're just still trying to understand what that process is. And I think of it almost like post-traumatic stress disorder, where after World War II, veterans came back and they had shell shock and no one knew what it was and what was going on. And now we know about PTSD, and we know it has a biological basis, and we know it has clusters of symptoms. So now we can understand it, but it took us a while to get there. And I think with NES, it's the same. We're just kind of at the beginning of it. So one interesting set of neurological findings when they do brain imaging, they find that in most people, if you have a feeling, before you have some sort of motor activity, your frontal part of your brain is going to regulate that in some way. So you're not like a little kid where you're upset and then suddenly you're blurting things out and shaking your hands frantically, you're regulating it. But in people with NES, certain parts of the brain, the insula involved in emotion, kind of go directly to the motor system and bypass these frontal control centers. So it's like you can feel an emotion and then have the motor system activated by that without having any control. So you can start to think about, people have these emotions, they're feeling them, all of a sudden they're having these seizure-like symptoms. And this study doesn't include epilepsy, but in epilepsy as well, stress, emotions definitely can trigger seizures because it's all your brain, it's all related. But people tend to think of emotions being crazy, but they're not. And so again, I think from my first slide, one of the main ways emotion researchers define emotion is as an adaptive set of responses. These are helpful for you. If emotional responses weren't helpful to you in evolutionary times, you'd be like killed by a bear because you wouldn't see the bear, feel fear, and then start running from it. So emotions are adaptive. But again, in our society, as we just heard, there's a lot of stigma against emotions. So let's see. We don't want to keep you here all day. So I think what I'm going to do is, well, present a little bit of data to you. So this is data not collected in our lab, but there's a group in the Netherlands, and they've done a lot of studies of emotion in psychogenic non-epileptic seizures, typically compared to epilepsy patients or controls. And they found that with people with psychogenic non-epileptic seizures, just resting, just sitting there, their cortisol system, their stress system is more activated. You can see by that top line. And that's especially true in people who've had early childhood sexual trauma. And people with psychogenic seizures, a huge percentage, almost all, have had a history of trauma, which leads neurologists to think, oh, the trauma has caused the psychogenic seizures. And it may be a contributing factor, but there are people with trauma who don't have seizures, or maybe they have PTSD but not seizures. So that's got to only be part of the story. So at rest, your brain is more active. Another thing we see in patients with these non-epileptic seizures is that their attention is attuned more towards social threat. And again, if you've had trauma, this is especially true. So if you see a picture of a happy face and an angry face and a neutral face, some people implicitly, without even realizing it, focus more on the angry face. And this is true if people have depression, if they have anxiety, and if they have non-epileptic seizures. And what's interesting is you see this under resting conditions. So you're just kind of sitting there, not doing anything that stressful. You see these pictures of faces, but it's triggering for you. And it also interferes with working memory. So if you're trying to solve a problem or hold information in your head, the emotions are intruding or intervening more. And then this was also kind of an interesting study that was done where they looked to see if people approach an angry face by holding their arms toward it or pulling your arms back. And so these studies seem kind of strange, but psychologists have to come up with all these clever ways, because if we say to you, are you anxious right now? You might say, no, I'm not, and maybe you're not, maybe you don't know you are. So we come up with these clever ways. So for example, you have to have your arms out or up. And so they found that people with these non-epileptic seizures were slower to approach an anger face. And so what's also interesting is that in epilepsy, if people feel angry, anxious, if they have lower self-esteem, they don't have more seizures necessarily. The seizure frequency is the brain having its electrical discharge, and that's what it is. Whereas with the non-epileptic seizures, you do see more links between these emotional processes like implicit hidden anxiety and the non-epileptic events. So our working hypothesis as emotion researchers who study non-epileptic seizures is that your nervous system is somehow hyper-aroused. Even sitting at rest, your brain physiology shows a more stressed state, so does your body, but then there are coping styles that suggest you should avoid these emotions. And so you can imagine if you're having emotions over time building up, and nowhere to go, the brain in some way might be protecting itself by kind of cutting itself off or disconnecting, and you end up having a seizure. So in our lab, the goal is to have you come in and feel emotions in the lab, because again, we can ask people what they feel, but it doesn't help unless you're actually capturing those emotions in the moment. Just in the way in the EMU, you have to capture the seizure events to be able to understand them. So in our lab, we bring people in to the West Campus. We study different aspects of emotion response. And here are some diagrams showing. We'll show people pictures We have other studies where we bring in couples and we have them fight, or we have them do affectionate touch, and we're trying to understand what people's emotions are like in their real lives and get those to come out in our lab. And so far, I'll just cut ahead to the chase, we're finding the same pattern of this hyperarousal and this avoidance. And one other thing I wanted to tell you about is, so you'll see we've passed out little flyers because, again, we can't do this research or learn anything, really about anything, without people experiencing it. So we are studying people with epilepsy and with non-epileptic seizures, especially if you're diagnosed, and we have some small grant funding, so we can pay you, so that's kind of cool. So you can look at the flyer and let me know if you have questions. But basically, you have a lab study, and then we've started really involving partners, spouses or romantic partners in our research, to some extent also caregivers, because those are the folks that really are with someone experiencing this and have a lot of interesting tips and suggestions and ideas. So we have lab studies, we have survey studies, so if you're interested in participating, let me know. And what we found with the partner analyses, first of all, it's really tough to separate the different seizure types. Unless you've had video EEG monitoring for 5 days in an EMU where you're having seizures that are similar to the ones you have at home, it's almost impossible to tell from your perspective, are you having an epileptic event or non-epileptic event? Someone has to really be trained and really be monitoring you, and even then it can be hard to tell. So if you're experiencing confusion with any of this, it's because it is confusing. And the spouse-partner relationships are one of the areas hardest hit. We expected that people in a relationship, especially if they were married, in our research to show that they had an easier time with their emotions, but we were surprised it actually was harder, because not only are you dealing with seizures, but you're worrying about the impact on your spouse and on your marriage and on your family, and so that's a lot of added stress. And so our findings would suggest that, well, if you're single, then you're happier because you don't have to deal with the impact on your marriage, but that's not necessarily the case either, because then you're missing this whole source of support. So it is a balance. And what's also interesting is that patients, especially with non-epileptic seizures, often get the runaround from healthcare providers. They go to a neurologist, to a psychiatrist. They can't figure out what's going on. And we found that if you're someone with better relationships overall, even starting in childhood, you actually have better patient-doctor relationships too. So maybe that's some good news. If you work on your relationships, it'll help your relationships with your doctor. And let's see. Yeah.
Because I knew a gal who said hundreds a day of seizures had her. She had surgery at the Cleveland Clinic, upstate New York, in Syracuse, also did surgery there. She went to the University of Pennsylvania, where they worked with a psychologist. And that cured those seizures. So it was not surgery.
Yeah, and so she's giving an example. Yeah, people can do the brain surgery, epileptic drugs, everything. Hopefully it doesn't get that far, because you'll have a good neurosurgeon like Dr. Zimmerman who's going to monitor you in advance. But yeah, there are these stories and people don't know. And so that's the good thing about the non-epileptic seizures, is if you're willing to say, okay, this isn't epilepsy. It's something biological, but it's not epilepsy. Psychological services typically work. We don't know how, we don't know why, but they work. And we think it's because you're making a lot of these unconscious processes about your emotions and your feelings more into your conscious awareness. And what we also know is that there are different types of people even with PNES. So the focus has been on separating epilepsy versus non-epileptic seizures, and now we know there are lots of different types of non-epileptic seizures too. And so for those folks, we have to look at different subtypes. So the more people we can study, the better, because then we'll see the range of possibilities. And so just to wrap up, I'm mindful I don't want to keep you guys here till like 3 in the afternoon with me babbling on. But in general, what can happen if you're someone with non-epileptic seizures is that you feel these feelings strongly and you cut off from them, even without realizing it. And some people who we've worked with in our lab are what I would call these super copers. They're like, well, I've lost my job and I've, gotten a divorce and all this stuff has happened, but I'm still going. I'm just having these seizures. And they're not making the connection that they're these super copers. They're just going, and their brain literally is not handling it. And it's kind of cutting off and ending up with these symptoms. At least that's our current working definition of it. There may be other things, in 5 years I'll come tell you something different about it. But that's, as of now, what we know. And then over time, it's conditioned so that you might be sitting there seeming to be in this neutral state, and all of a sudden you're still having these symptoms. So that would kind of explain through these conditioning processes, these psychological processes, why it might seem you're just sitting and relaxing and all of a sudden having these seizure-like symptoms, which again, if you have epilepsy, your brain is doing this neural firing. Like Dr. Chung was saying, we don't know why your brain sometimes will decide to have neural firing. But with psychological services, what we try to do is track and monitor in the way if you were having a panic attack, you can track and monitor what are the circumstances and what are the thoughts in my head that are leading to this. And so if the problem is that we're disconnecting from our feelings or from other people, then presumably the solution, and there's some evidence to support this, is reconnecting. And so the other good news is that there is growing awareness about non-epileptic seizures. Lorna Myers, who's a figure, part of the Northeast Regional Epilepsy Group, who's a big figure and clinician in this area, has a book that's sort of this hands-on psychogenic non-epileptic seizures guide. There are treatment guides now for therapists, but it is really tough in Arizona. Mental health services, as we just talked about, are very fragmented. If you're interested, we've put together a list of behavioral health resources that are low fee, sliding scale fee, so if you let me know, we can send you our list of resources. And the Epilepsy Foundation, they're the folks supporting this, and so there's certainly a resource for you. So thank you to all our research participants and to you for your attention, and to my lab and collaborators. Yep. Yeah, 43rd and Thunderbird, that's where we are. That's a good question. This is something we've debated. She asked, are we studying people with epileptic and non-epileptic events? For our survey, we're pretty much taking everyone. For the lab study, we're being a little bit more particular to try to have people who have either the epilepsy or the non-epileptic events. In previous research, what's interesting is that people with a mixed diagnosis tend to show some of the emotional characteristics similar to the non-epileptic group. So, yes, if you're mixed, maybe let me know. I have a hard time saying no to participants. Yeah. All right.
Thank you very much. I think we need to take a break because I can't locate my next speaker. He was here, and I don't know where he went.
Thank you very much. That was really interesting.
Thank you.
Is the cannabis person next? Is it Trout who's next?
Yes.
Okay.
Oh, there he is. He's here. He's polite.
Never mind. Dr. Trout is here. Okay.
Thank you very much. No, thank you.
I'll hook you up.
Alright, so it's on your waist. And let's see, he told me that.
Next we have Dr. William Powell. Currently serves as a medical director for 6 Arizona licensed medical cannabis dispensaries. He was the first dispensary medical director in Arizona. He's trained hundreds of dispensary agents throughout Arizona, and he's authored Arizona's first approved medical cannabis educational materials to provide to over 10,000 patients.
You can stand here or wander. If you wander, you want me to slide. If you want me to
That's okay.
Or we
Oh.
just slide that kind of
Designated
form.
as a treating physician
I'll come. I'll be
and
here.
expert witness in an Arizona court case. He testified, his testimony included cannabis as treatment for seizures, proper dosing of seizures, proper methods of administration, and appropriate extraction methodologies. He graduated magna cum laude from ASU with a degree in biology and received his medical degree in naturopathic medicine from Southwest College of Medicine.
Wow, thank you. Thank you very much. Pleasure to be here. All right, medical cannabis. Let's have some fun. So first of all, a little terminology. You'll definitely hear me using the word cannabis, and cannabis is the botanical name that's accepted for this plant. Marijuana is actually a slang term that came about in the 1930s specifically for the efforts of prohibition. Reason being, because up until that time, cannabis was actually one of the major cash crops in this country. We get this impression that this cannabis thing is this new wonderful herb that we just pulled out of the Amazon somewhere, and the truth of the matter is that this plant has been with us as long as we have written history. So yes, this was our major cash crop in this country up until the 1930s. Everything was made out of it. First Levi Strauss jeans were made from the cannabis plant. First American flag was made from cannabis fiber. First draft of the Constitution made from cannabis paper. All the newspapers were made out of cannabis paper. The sails and the rope that brought our ships to the New World, all made from cannabis. In fact, the term canvas comes from the word cannabis. So they couldn't really tell the farmers in the United States they were getting ready to make their main cash crop illegal. So hence the term marijuana, which was again this slang term with Hispanic origins. And it came about with a lot of propaganda and just straight misinformation about what this plant actually does. The other term, hemp, is just another common term for this cannabis plant, except typically now it's used more for the industrial purposes of the plant. So the fiber uses, the building materials, or also the plant medicines or plant products that are being made with small amounts of THC in it are now being referred to as hemp products. The legal distinction is about 0.03% THC, so less than that is being referred to as hemp and again cultivated for legal purposes. Like there's still a bit of gray area in there. We want to remember that this plant is still a Schedule I drug on the federal level, so it does still have consequences on the federal level for its use. But again, as far as medical purposes, we've got over 4,000, we've got medical literature on this plant that goes back 4,000 years describing its uses. It was in the United States Medical Pharmacopoeia up until all the way through the 1930s that described its medical use. In fact, some pharmaceutical companies that you'll recognize, Park Davis and Company and Lilly, had cannabis medicines and extracts available up until that time period. And then in 2010, here in Arizona, the citizens of Arizona had the good sense to pass the Arizona Medical Marijuana Act, which created an immunity for patients here in Arizona to use this plant medicine legally. And then you can see that these are the qualifying conditions that include seizures, including those characteristic of epilepsy. So cannabis, this plant, this is a very complex plant. There are up to 400 plus different chemical components or constituents that have been isolated from this plant. And different plant strains or different types of the plant can have different levels of these constituents in them that can give them different medicinal properties or cause them to be experienced differently by the user. Cannabis sativa is one of the main types of cannabis. It's available at dispensaries. And the sativa strains are typically known to be more uplifting, more energetic, more of a cerebral sensation as far as that psychoactive effect is concerned. Our cannabis indicas are reported to be more relaxing, more sedative, more of a full body type of sensation. But these phytocannabinoids, let's talk about these because this is what makes this plant so unique. Of all of those chemical constituents within this plant, we've identified up to 100 of these components that we call cannabinoids. We named them after the plant because they are so unique to just this cannabis plant. And of these cannabinoid constituents, we call them phytocannabinoids. Phyto just means plant. So these are cannabinoids that came specifically from a plant source, the cannabis plant, in fact. Tetrahydrocannabinol, THC, and cannabidiol, or CBD, are the two major cannabinoids that are found within this plant. THC is the one that has the psychoactive effect, or the euphoria, what people call or is known as being high. Also the portion of the plant that causes the most controversy, obviously. But then we're also learning more about these other plant cannabinoids that are totally non-psychoactive. They don't have that euphoria that comes with it. Cannabidiol, CBD, being one of them. Even though it is non-psychoactive, though, we know they have many biological effects and medicinal effects inside the body. In fact, the federal government patented cannabidiol in 2003. And in their patent, they talked about what a great anti-inflammatory it is. They also talked about what a wonderful antioxidant it is. But most impressive, they talked about what a wonderful neuroprotective it is, that it actually protects brain cells. So everything that you've heard about smoking pot kills brain cells is just absolutely not true. In fact, we know that these cannabinoids, many of them have this neuroprotective effect to them. And I listed 3 other minor cannabinoids out of the 100 here. And the reason that I mentioned these 3 minor cannabinoids is because they've also been shown in preclinical animal studies to have anticonvulsant effects as well. And that's tetrahydrocannabivarin, THCV, cannabivarin, CBDV, cannabidivarin, pardon me, and cannabinol, CBN. Now, most of these minor cannabinoids are only found in less than 1% by weight in the plant, but it's believed that it's actually a synergistic effect between all of the cannabinoids and other constituents in the plant that are providing the true medicinal benefit of these plant medicines. Cannabinoid acids. Now, here's something that's real interesting about these cannabinoids, is that when they're found in the raw, fresh cannabis plant, they have a carboxylic acid group attached to it. So THC is actually THCA when it forms in the fresh green plant. Now, this is significant because THCA does not have the psychoactive effect associated with THC. So potentially, someone could eat a truckload of fresh green cannabis and not get any psychoactive effect at all. It takes aging or heat to decarboxylate or activate that THCA over to THC. So that's why the smoking of cannabis wasn't an accident. It was to provide the heat to activate this medicine and make it psychoactive. Or the cooking it into foods or the notorious brownies or cookies. Again, that was part of activating this medicine and making it psychoactively potent. And then cannabidiolic acid, CBDA, again, also forms in this carboxylic acid group. Now, CBD or CBDA are not psychoactive, so it doesn't have the great dosing implications as the differences between THC and THCA. But what we know about these cannabinoid acids is it appears that they are much better anti-inflammatory agents than the activated counterparts. They're also much better antioxidants. THCA is about 50 times greater antioxidant than THC. We also know that CBDA has selective COX-2 inhibition properties, which is just an anti-inflammatory pathway that it blocks. So again, these cannabinoid acids also have great medicinal benefit and potential as well. So our terpenoids, or the terpenes, this is the part of the plant that has the smell or the aroma, the characteristic aroma that goes with the cannabis plant. Even though they're non-psychoactive by themselves, we know that many of these terpenes have many great medicinal effects. Many of them are anti-inflammatory. Many of them have anti-cancer effects. And some of them have anti-convulsant effects as well, such as linalool that I listed down there. Linalool is also found in great concentrations in lavender, and that's where you get that characteristic lavender smell from this linalool terpenoid. And again, these terpenes are absolutely part of the synergistic effect, or what we call the entourage effect. Again, the entourage of all the cannabinoids and the terpenes working together. So we've known that cannabis has had anti-seizure effects since antiquity. It's been reported. In fact, here's a case study that goes back to 1947. In this one, it was a clinical trial with 5 institutionalized epileptic children. All of them had severe symptomatic grand mal epilepsy. And the results they saw were 3 responded at least as well as to previous therapy, and the 4th became almost completely seizure-free, and the 5th became entirely seizure-free. And this is 1947. So why is it that we've known about this for so long and it's just getting all of this attention? And the reason is because we're finding out so much about how this plant works in the human body. In fact, we've learned an incredible amount over the last several decades about our own human physiology just based on the way this plant interacts with our body. So, how does this stuff work? What's going on? Up until 1990, we really had no idea. We thought it was just increasing our endorphins, and that's what people were experiencing as that euphoric type of effect. However, in 1990, researchers found that there's a specific receptor in our brain that THC binds to. Up until that time, they had no idea that receptor even existed. And it turns out that we have more of these receptors than almost any other type of receptor in our brain. And what does that tell us? That says that this is a big part of how our body does business, these cannabinoid receptors. And now, finding that receptor in the brain actually stimulated more questions and answers for the researchers, because they're thinking to themselves, now, wait a minute. There's no way we developed the receptor in the brain just so we could get high off this cannabis plant. There's got to be another reason that we have this receptor. So they start looking for this natural molecule that our body makes that binds to that same receptor in the brain. 2 years later, they find it. Our body makes this natural chemical that binds to that same receptor in the brain that THC binds to. And they named it anandamide after the Sanskrit word meaning bliss. They also called it an endocannabinoid. Endo because it's made in our body, and cannabinoid because, again, it binds to these same receptors that these cannabinoids in the cannabis plant activate. Now it gets a little more complex. A couple different subsets of these receptors, CB1 receptors that are located all through our brain, spinal cord, our nervous system. And then we have a second subset of these receptors called CB2, or cannabinoid 2 receptors, that are located most densely throughout our immune system. And then a couple different types of cannabinoids as well. We've got anandamide and then 2-arachidonyl glycerol, or 2-AG. And then we've got a couple different types of enzymes that break those endocannabinoids down after they're done being used. So, what exactly is going on with these endocannabinoids inside our brain and inside our nervous system? What we have here is it's the synapse of 2 nerve cells coming together. And what we're finding out, this endocannabinoid signaling, they call it, we're actually calling it retrograde signaling. These are the only neurotransmitters that we know of that go back upstream. All the other neurotransmitters in our body go from top down. However, it looks like this is a check and balance system. So what happens is when the electrical activity in our brain becomes too excessive or too erratic, the postsynaptic nerve starts sensing that there's too much electrical activity going on, and it starts producing these endocannabinoids. Then they go back upstream and bind to the cannabinoid receptors on the nerve upstream, and through calcium channels and getting neurotransmitters like glutamate back into check, again, it brings that electrical activity back into balance. So again, this endocannabinoid system in our brain and nervous system is a check and balance system. That makes this system very unique compared to the other neurotransmitter systems in our nervous system. So this endocannabinoid system, found in all vertebrate organisms, so anything with a spine has this endocannabinoid system, basically a messenger system for the body. It allows the nervous system and the immune system to talk to each other and bring things back into balance. We call them neuromodulators because when it's activated, it balances or changes our nervous system. We call them immunomodulators because when it's activated, it balances or changes our immune system. And this, if you think about it, again, this check and balance system is about homeostasis, or keeping the organism in balance with its environment. And also, if you think about the effects of cannabis, it relaxes people, it makes them sleepy, it makes them hungry. Those are rejuvenation type of activities. Again, this is a homeostatic system. So this is a great journal article, review article, for those of you who are interested in the mechanisms of action of these non-psychoactive cannabinoids. And it puts together a real nice information packet of how they work. And this is one of the pictorials that they give in it that kind of condenses the information. Now, we thought it was nice and cut and dry, right? A couple cannabinoid receptors, couple endocannabinoids, pretty easy. Now we start seeing that this endocannabinoid system gets very complicated and complex. So let's just look at cannabidiol, or CBD, at the top of this pie graph here. So reduces anxiety through CB1 receptors, 5-HT1A receptors. It's an antipsychotic through, and again, these are preclinical studies mostly with mice and rat models that they've gleaned this information. Antipsychotic through TRP1 channels, anti-epileptic, not through the CB1 and CB2 receptors, but directly through calcium channels. Neuroprotective through calcium channels, the ROS system, vasorelaxant through PPAR channels, antispasmodic, anti-ischemic, anti-cancer effects through calcium channels, ROS system, antiemetic, antibacterial, anti-diabetic, anti-psoriatic, intestinal antiprokinetic through the Fa and calcium channels, analgesic, bone stimulant, reduces TNF-alpha adenosine uptake for anti-inflammation, reduces T cells, has immunosuppressive effects. So again, this endocannabinoid system touches almost every other system. It affects and balances our serotonin systems, our dopamine systems. It's an emotional buffer that balances the cortisol release in stressful situations. So again, this system starts becoming very complex, but remember, it's a check and balance system. It wants to err on the side of homeostasis in most cases when it's activated. So let's take a look at some of the dialogue that the medical researchers are proposing. And I don't want you to think that it's just Dr. Trout saying all this stuff. I am getting it from somewhere. This was published in Neuron 2006. The endocannabinoid system controls key epileptogenic circuits in the hippocampus. Pardon me, hippocampus. I get that cannabis thing on the tongue. It rolls off real easy. The endocannabinoid system tightly controls neuronal excitability. So what we're talking about is that this endocannabinoid tone, there's a tone or a level of these endocannabinoids that become common in different individuals. And what they see is that when this endocannabinoid tone is high, or there's a lot of these endocannabinoids around, that it raises the excitability threshold for seizures. So it's harder to get to that seizure point. When these endocannabinoids, or this endocannabinoid tone, is low, that threshold is much lower, and we see that excitability can cause these seizures much easier. Cannabidiol displays anti-epileptiform and anti-seizure properties in vitro and in vivo, Journal of Pharmacology, 2010. Seizure, 2012, cannabidiol exerts anticonvulsant effects in animal models of temporal lobe and partial seizures. So in this study, they used doses of cannabidiol in 1 milligram per kilogram, 10 milligrams per kilogram, and 100 milligrams per kilogram in this animal model. And what they noticed is that CBD doses of 10 milligrams per kilogram or greater significantly decrease the mortality of rat as due to seizures. CBD in all doses also decreased the number of animals experiencing the most severe tonic-clonic seizures. Epilepsy, 2010, delta-9 tetrahydrocannabivarin, so that's that THCV, suppresses in vitro epileptiform and in vivo seizure activity in adult rats. British Journal of Pharmacology, 2012, cannabidivarin is anticonvulsant in mouse and rat. Neuroendocrine Letters, 2004, on the application of cannabis in pediatrics and epileptology. So this is an interesting one right here. So what they did is a case study with Marinol. What Marinol is synthetic THC, which has actually been available in this country since the 80s, FDA approved. So it's been possible for people to get a prescription for THC or Marinol since the 80s. And I think this goes a long way to solidifying the importance of that synergistic effect of all the cannabinoids. Because if it was just THC that was providing the medicinal effect, we wouldn't be talking about the cannabis plant right now. Everybody'd be running around with a prescription for Marinol in their pocket, and it wouldn't even be an issue. But again, this is absolutely a synergistic effect between all of these cannabinoids that are providing the relief. So in this study specifically, it was a case study with 8 children using Marinol, and they used doses from 0.04 to 0.12 milligrams per kilogram body weight a day. And in these doses, it was tolerated very well. And what they saw was that THC affected reduced spasticity, improved dystonia, increased initiative with low doses, and increased interest in the surroundings and anti-convulsive action. However, they saw in doses higher than that it caused disinhibition and increased restlessness. But the interesting thing with THC is, again, THC has those psychoactive side effects that go along with it. So it's much variable as far as what the outcome is. And also in many other animal studies, what it's starting to look like is that there's quite a tolerance with THC. And in the higher doses, they were seeing a tolerance within like 6 to 10 days where it just wasn't working anymore, it wasn't effective anymore. And we do not see those tolerances with CBD and some of these non-psychoactive cannabinoids that work through other mechanisms other than the CB1 and CB2 receptors. Epilepsy and Behavior, 2012, seizure exacerbation in 2 patients with focal epilepsy following marijuana cessation. So there are reports of people that have been just smoking cannabis that have received benefit or reduced their seizure activity. And in this case study specifically, there were these 2 patients who went into inpatient care and stopped using marijuana while they were in there. And they noticed that their seizure activity came on quite strong when they stopped using cannabis. And then when they left that inpatient care and went back to their regular cannabis use, their seizures were controlled again. So again, there are reports of people just smoking cannabis and getting relief from seizures. But at the same time, I want to say that there are reports of people smoking cannabis and having their seizures exacerbated as well. So again, it's something that people need to be real careful with these, especially these high THC type of dosing. And this here is pretty much the only double-blind placebo-controlled study that we have with cannabis and seizures or cannabidiol. This was published in Pharmacology in 1980. And what they used, the group they used was 8 children, and the 8 children that had seizure disorders, and 8 children who were totally healthy. Pardon me. This is actually an adult study. This is not a pediatric study. So this was in adult patients. They used 8 patients with seizure disorders, and then 8 patients that were totally healthy as well, just to see how they tolerated the medicine. And then they also had a placebo group. They used doses of 3 milligrams per kilogram body weight daily. And what they noticed was all patients and volunteers tolerated the CBD very well, had no signs of toxicity or serious side effects were detected on examination. 4 of the 8 CBD subjects remained almost free of convulsive crisis throughout the experiment, and 3 other patients demonstrated partial improvement in their clinical condition. But CBD was also ineffective in 1 patient. And now as far as the placebo group was concerned, 7 of the placebo patients remained unchanged, and 1 of those patients just thought it was going to work so darn well that he had great benefit from the placebo. This one talks about the antioxidant effects from cannabis. And in this study, what they saw is that cannabidiol was actually more effective than vitamin C and vitamin E for protecting brain cells against oxidative damage and glutamate toxicity. And with the patients that we work with, one of the interesting aspects that we're seeing is even when they do have breakthrough seizures, we're seeing that their bounce back time is so much better. When they used to be wiped out for like a week after having a heavy bout with seizures, they're bouncing back the next day. And a lot of that could be due to, again, this antioxidant protective effect that we're seeing with these cannabinoids as well. So other factors that affect this endocannabinoid system and may have the potential to benefit patients. So cannabis obviously activates this system, and we'll talk about some of the medicines that our patients are using shortly. But there's other things that patients can do as well. Exercise increases our endocannabinoid levels significantly. There's actually some researchers that are starting to believe that runner's high that we used to think was just the endorphins that were being increased in our body may actually be the increase in our endocannabinoids that individuals are experiencing. Diet, eating essential fatty acids, omega-3, 6s, and 9s, significantly increase our endocannabinoids. In fact, we use these essential fatty acids as a precursor to make our own endocannabinoids. Americans are very deficient on essential fatty acids, the standard American diet. Maybe that's why so many Americans are craving cannabis, is just because they're not getting the nutrients they need to make their own endocannabinoids. Ethanol, nicotine, and caffeine will all affect that endocannabinoid system. Stress reduction, we see that chronic stress definitely affects the amount of cannabinoid receptors that we have and their distribution throughout our brain. Spinal massage, spinal manipulation. Saw one study in osteopathic spinal manipulation increased in anandamide levels significantly. So you know that feeling when you get off the massage table, that might be the increase in those endocannabinoids that individuals are experiencing. And possibly meditation has the ability to do that, have that same type of effect as well. And then over-the-counter medications and pharmaceuticals also interact with this endocannabinoid system. In fact, the pharmaceutical companies are working like crazy to make synthetic cannabinoids that bind to these cannabinoid receptors and activate this endocannabinoid system. The problem that they're having is that it's such a complex system, and again, it is a synergistic effect between all the cannabinoids that provides the medicinal effect, is that synthetically they're having a really hard time reproducing that synergistic effect that we get from all the cannabinoids. So what we may see as far as the first cannabinoid medicines that show up available from pharmaceutical companies are such like this medicine called Epidiolex, which comes from GW Pharmaceuticals. It's a purified cannabidiol extract, but it's a whole plant extract, so it does have all of the lesser cannabinoids in it as well, other than THC. They've excluded THC to minimize that, any of those psychoactive side effects. They were granted orphan drug designation in November of 2013. They've expanded their access to treat approximately 420 children and an additional 225 people under 4 U.S. state programs. If anybody's more interested in this, you can see the information that's available at gwpharmaceuticals.com. So this is the preliminary data that they gave us over a year ago. And they released information on a group of 27 patients. And what we saw is that, or what they're reporting, is that 48% of all patients obtained at least 50% reduction in seizure frequency as compared to baseline seizure frequency. 41% of all patients obtained at least 70% reduction in seizure frequency as compared to baseline seizure frequency. 22% of all patients obtained at least 90% reduction in seizure frequency as compared to baseline seizure frequency. And at the end of 12 weeks, 15% of all patients were seizure-free. Now they've just released here this last year another batch of data for us on 137 patients. And on those patients, they saw it at the end of 12 weeks, 9% of all patients were seizure-free. They saw promising signals of efficacy with median 54% reduction in seizures after 12 weeks treatment and maintenance of clinical effect at 24 weeks. Epidiolex was well tolerated and 90% of the patients remained on treatment. The side effects that they did see was somnolence, fatigue, some diarrhea, and these are mild to moderate side effects, but those were the most common ones that they saw. And what they did was they added this Epidiolex to the drug regimens that these patients were already on. And in some instances, it was associated with changes in serum concentrations of the concomitant medicines that they were on. So these cannabinoids are metabolized in our liver, the same place that these other medications are metabolized, and there is the potential to change the clearance of these other medications. Clinically, what we're seeing with the small doses that most patients are using, that it's not a significant change. However, this is something that patients and physicians will definitely want to keep their eye on. So most of our patients are using this medicine through oral routes. Again, smoking is not the most effective way to get these non-psychoactive type of cannabinoid medicines into the system. Now again, we see these edibles in a lot of these dispensaries, brownies and cookies, horrible, horrible. They're full of sugar. Sugar is very inflammatory. This is an anti-inflammatory medicine. Why would you take something that's supposed to reduce inflammation with something that causes inflammation? Just unbelievable, makes no sense. They're also very hard to dose, and they've got a lot of variability with the amount of the cannabinoids that are actually in these types of medicines. However, some of our more medically committed dispensaries you're starting to see more standardized medicines showing up, like the herb itself ground up into capsule form, which again, much more standardized, easy to use. Many patients are using it in the extracted essential oil form that concentrates these cannabinoids into a much smaller dose. At the Harvest of Tempe, it comes in a syringe form because this oil is very thick and sticky. It gets on everything. It's very hard to work with. So in a little syringe, they can just squeeze out little boluses and get a much more standardized dose from it. And then tinctures, or the extraction could be mixed in a liquid vehicle like vegetable glycerin or fractionated coconut oil. And again, that makes it much easier to dose out drop by drop and get more of an exact standard dose out of the medicine. And then raw, juicing of it or eating the raw plant is a great way to get those cannabinoid acids that again have a better anti-inflammatory effect, antioxidant effect, and much less of a potential to have any of those psychoactive side effects that come along with it. Tea, or someone who wants to activate the medicine, tea is another great way to do it. You can get one of these double-walled teacups right here, grind up the herb, throw it in the bottom of your teacup, put your steam water on it, put the lid on, set it aside for about a half an hour, and that'll do a good job of decarboxylating those cannabinoid acids to get them into more of that active form. Then they can drink down the tea, swallow the cannabis, and get a really good dose that way as well. So dosing. In the 2003 U.S. government patent on cannabidiol, they said that therapeutic doses were between 5 and 25 milligrams per kilogram per day. Now, those doses can get quite high and actually be quite expensive as well. But what we're seeing is that many of our patients are reporting good results in between 1 and 5 milligrams per kilogram body weight per day. And these plant medicines, they get, again, the dispensaries that are very medically oriented will test these plant medicines and get a percent constituent weight of, so the amount of THC by percent weight that's in the plant material. And then once you know how much THC or how much CBD is in that plant material, then you can get a standardized CBD dose out of that plant material. And one of the things that opponents say about these plant medicines is because they're plant medicines, they have their constituents are variable, and it's really tough to get a standardized dose. But again, by testing out that plant material and finding out exactly how much of the constituent that's in it, when you go from one plant generation to the next, you can readjust those doses to go ahead and get more of a standardized dose out of that medicine. And then also at harvestinghope.com, we do have a dosing calculator that's there that can help individuals plug in what types of medicine that they're using with the concentrations of the constituent that's in there and help them get their head around the dosing and get more of a standardized dose. I also do on-site office hours at the dispensaries I work with, as well as new patient orientations, and I'm available to patients to help answer any questions that they may have based on dosing or anything else. And again, I want to thank you so much for having me here today. If you got time. Absolutely. Absolutely. Oh, thank you.
Thank you, Suzanne. Can everybody hear me? Am I hooked up well enough for you to hear what I'm saying? Okay, let's try this. Can you hear me now? Yes. Yes? Okay, good. Thank you for inviting me to be here today. I appreciate it. I also know that it's the end of a Saturday and you've been here all day and you're probably looking at your watches and wanting to go home, and I don't blame you a bit. I won't hold yawning or any kind of daydreaming against me personally, so if you feel the need, go right ahead. And if you feel that you want to interrupt my presentation and ask questions during, that's fine, and if you'd rather not ask any questions and get out faster, I understand. But let's get started. Oops. Okay. I'm just going to go over some of the main laws that, that cover disability rights, particularly in epilepsy. I know that we're talking about epilepsy today, but you know, epilepsy is a recognized disability under many of our laws, both nationally and under state laws. And so there are some that we hear about all of the time, and you probably hear about all of the time. Some are very specific to different settings. All of them overlap with one another, but very frequently people don't really understand which ones are implicated when. And so I thought I'd give you a brief overview. There are a lot of state laws and also local policies that also apply. I won't be going over all of those, or we would seriously be here the rest of today and probably into tomorrow. So I'm just going to hit the highlights for you. If anybody has some really in-depth questions or particular questions that either apply to you or the work that you do or your family members, you're certainly welcome to contact me at any time. But the four main laws that control equal rights and lack of discrimination for people with disabilities, including epilepsy, are the Americans with Disabilities Act, which is one I think everybody is familiar with and you hear about all the time. I'll talk about that a little bit. The Rehabilitation Act of 1973, which most people don't know about, but is actually implicated in all of these laws very regularly. You may not recognize it, but this is the act that if you ever hear about Section 504, Section 504 plans in education and Section 504 rights regarding reasonable accommodations, that's what we're talking about, the Rehabilitation Act of 1973. We have the Individuals with Disabilities Education Act, which is the one that comes into play for any of you that deal with children and special education settings, IEPs. It's the IDEA that we're talking about that deals with special education laws. And then, of course, we've got the Fair Housing Act, which covers a myriad of disabilities, including epilepsy, and the rights that people have for fair housing despite any disabilities they may have. So we'll talk about a little of each of those just a little bit today. The ADA, of course, is the overarching act in the United States. It's a federally recognized act and allows everybody with disabilities to have equal access and not be discriminated against in employment and in any kind of setting or program where federal dollars and federal funds are involved. In this particular act, it says that anybody who has a physical or mental impairment, and it's important that it includes both physical and mental disabilities, anyone who has one of those disabilities that substantially limits any major life activity is considered disabled under federal laws, and those people cannot be discriminated against either in employment or in any sort of program where federal funds are implicated, including education. So both our schools and our private and government employers are prohibited from discriminating against people who have disabilities. We're going to talk a little bit about who qualifies as having a disability and who doesn't, because there are people that have maladies that do not actually count as disabilities, and we can talk a little bit about that. But under the ADA, the criteria is if it interferes with one of your major life activities, then it is considered a disability. And major life activities include things like breathing, eating, walking, sleeping, taking care of yourself, cooking, working, reproduction. Pregnancy rights are huge now under disability laws, as are productive rights for fathers if people don't think about it. But for people who are going through fertility treatment, whether you're male or female, your right to leave work early and go seek treatment and not be discriminated against for that is also a protected right these days. And the other two important things are you don't have to be recognized as having a disability, for instance, through Social Security. We hear about people who are getting Social Security disability benefits or get Social Security supplemental income because they've been determined disabled by Social Security. But you don't have to have gone through that process to actually be eligible for the protections under the ADA. So you could be working and collecting a paycheck and never have missed a day and never get a disability check and never go through Social Security and still be considered disabled and still have a right to protection. So don't confuse the need to have Social Security benefits with the right to have protection benefits under the law for having a disability. And it covers you not only if you have a personally recognized disability, but believe it or not, it covers you if you have a record of having a disability, or if you have been treated as having a disability, even if you don't have a disability. So there are instances where people have been in a work environment where they thought they had a disability, their employer thought they had a disability. It doesn't actually meet the definition of a disability under the ADA, but if that has been recorded in your employment record and you have been treated and accommodated as if you had a disability, you have the same rights to disability protection for things like your employment as you would if you actually had the disability, until such a time as, all of that sort of thing changes and they change your records and everything gets updated. But if you have a record of having a disability, even if you don't have one, you have the same protective rights as everyone else. I think a lot of people don't recognize that, so it's something important to think about. The ADA doesn't specifically name the disabilities that are covered, and quite frankly, they don't do that because there's a very long list. And so it's on a case-by-case basis. But there are some examples of things that almost always qualify for disability. And as you can see, epilepsy is one of them. The other things are things like cerebral palsy, multiple sclerosis, certain heart disease, not all heart disease, certain diabetes, not all diabetes. This is an old list taken from the government, so don't be offended by words like mental retardation. That actually comes out of the statute. It's not a word I used. Emotional illness, certain emotional illnesses, not all of them. HIV disease, whether it's active or non-active, symptomatic or non-symptomatic, are on the list. We see that sometimes. Tuberculosis, I don't know how many people have that anymore, but it's still on the list and it's covered. And believe it or not, some drug addiction and alcoholism is also covered. The caveat with drug addiction and alcohol, drug and alcohol addiction is that you can't, if you're seeking treatment for it, you're covered for the treatment, but you can't be using drugs and alcohol and missing your treatment and then seek the protection. So if you are, for instance, an alcoholic who goes to your employer, let's say, as an example, and you want special accommodations to leave work early because you're going to be in a drug and alcohol treatment program, they have to provide that accommodation to you. If instead you leave and you decide to go drinking early in the afternoon, then you're not covered. You don't get to use your disability protection in order to participate in your disability addiction. So they're not quite that liberal with things. Section 504 of the Rehabilitation Act works in concert with the ADA. And Section 504 is what gives us the language that I think we've probably all heard. You hear it all the time. 504 is the special accommodations, right? So you have to be given a reasonable accommodation. And what does that mean? Well, it means that if you have a disability, you get certain protections, but it isn't an overall blanket that means you get to have anything you want. So reasonable accommodations, and we'll talk about them a little bit more, come from the Rehabilitation Act. They're woven through the ADA and some of the other standards as well, and you'll see it even right down to fair housing where we see reasonable accessibility. But basically it means that in recognizing disabilities, we can't treat everybody with a disability exactly the same as everybody without a disability, but we have to make whatever reasonable measures we can to provide them equal access and equal participation in our services in the community and participation in our life. So Section 504 is the magic answer for that. When we talk about the ADA and employment, and today I'm only going to cover a few things, because again, if we were talking about disabilities in the law, we could do a whole week discussion on disabilities in the law. So I'm hitting just the highlights, and we're going to talk mainly about employment, education, and housing today, just the highlights. The ADA prohibits employers from discriminating against qualified individuals with disabilities throughout the entire employment process. That means the way that they advertise, the way you go through job application, completions and interviews, how you're hired, how you're screened, how you're tested, how you're monitored afterwards, and how your exit interview goes with your employer as well. And so there are many standards that determine whether or not you're being discriminated against. We can talk about them in particular ways, but you see them mostly when it's things like, for instance, this happened to me the other day. Somebody needed to come in for actually a legal consultation, and it applies to all employers of 15 or more, including law firms of 15 or more. And I had somebody who wanted to come in for an interview and they were deaf, and I don't have a TDD system at my office, believe it or not. And so I had to make accommodations to actually meet them somewhere because they couldn't get to my office. They didn't have a driver's license. They were from Colorado. And so I made an accommodation for them, and I met them somewhere so that they could read my lips and talk to me when we were meeting. And so that's the kind of thing that if you ordinarily do a telephone interview, you've all been there at an employment screening where they say, let's have the first interview be by telephone before we make you come downtown, right? If that first interview can't happen by telephone, they have to provide you an accommodation, and that means getting a TDD system, meeting you in person, or offering to have you come down twice. But they can't say, well, if you can't do a phone interview, which is our first process, then you can't apply for the job. That's not allowed. If you are blind and they only have paper forms and it isn't in Braille and they don't offer you something else, that's not allowed. They have to be able to give you an opportunity to apply the same as everybody else. That means everything from access to the building, making sure you can get up a ramp to get to the interview room, making sure that you can receive communications when they're telling you about who's been screened for the job, and whether that means email, written mail, telephone calls, or some other form of communication. They have to keep you involved in all of that too. At any place during the process where somebody with a disability would somehow be treated differently and unfairly compared to their non-disabled counterpart, that could be considered discrimination, and that's where your rights come in under the ADA. So think about that when you're either for yourselves, your family, people you work with. And it's important that you know that the law extends not only to employers themselves, but also to like staffing agencies, temporary staffing agencies, the Kelly Girls of the world and the account temps and whatever, as well as labor organizations and unions. So you need to think about that. If you have a disability, you must, however, having the disability itself doesn't give you the protection. You only get protection if you have a disability if you would otherwise qualify for the job. So if I am hiring for a radiologist position and you're not a doctor with a degree in radiology, just because you have a disability doesn't mean you get the job because you get some sort of special treatment, right? You have to otherwise qualify for the job, and you have to be able to perform the essential functions of the job. And those are the two key factors, is that you must otherwise qualify for the job, you must have the appropriate education, experience, background, and ability to perform the job, and then you must be able to do the essential functions of the job with or without accommodation. What does that mean? It means that if you are applying for a job as a driver and you don't have a driver's license, then you obviously don't qualify for the job regardless of whether or not you have a disability. But if you're applying for a job as a driver and you have a driver's license, but you have a bad back because you have a chronic problem with you have scoliosis or something, right? And you need a special seat put into the truck that you're going to drive every day, or you need a special cushion that lifts you when you sit behind the wheel for 4 hours. That's a reasonable accommodation, and your employer is required to provide that for you. And in fact, when you go into a job interview, and you're talking to your employer about your ability to do the job, they're not allowed to ask you if you have a disability, and they're not allowed to ask you if you need special accommodations or what those accommodations are. All they can ask you is, are you able to perform the essential functions? And if you say yes, that is where the inquiry stops. Now, employers can request that you pass certain performance standards, but only if they do that for everybody, not just for somebody with disability. One of the questions I get all the time is it all right if my employer tells me that I have to take a medical test or pass a medical screening in order to get a job? Because that doesn't feel fair to people who have medical problems that may be revealed in a medical exam. And the answer to that question is yes, your employer can ask you to undergo and pass certain medical criteria, but only if every other person who applies for that job is required to undergo the same medical exam and pass the same medical criteria. So if they're doing it because passing a medical exam and meeting certain medical criteria is required in order to demonstrate an ability to perform the job, for instance, being a firefighter or a police officer where you have to be able to run so fast or lift so much weight or perform a certain number of tasks, and everyone who applies for that job has to go through that same criteria credentialing, then they can ask you to do it. They can't ask you to do it if they're only asking you because they suspect you won't be able to because of your disability. Yes?
When you're in the interview process, you want to be honest.
I'm sorry, say it again?
When you're in the interview process, you want to be honest.
When you're in the interview process, you want to be honest, yes.
One should bring up or have just should not discuss.
So, as a lawyer, I'm going to tell you this. Never volunteer any information people don't ask you for, ever.
You're not coming across this law, so if my daughter gets hired, she has a seizure for the job, they can't get back, so you should have told us before.
Well, they can say whatever they want, but they can't fire her for her not telling you. So, no, right, that's exactly right. If she does not disclose she has epilepsy, and I hate to say it, but my recommendation would be that she not disclose that she has epilepsy, partly because it's none of anybody's business, and secondly, it's because they have no business taking that into account when they're going to hire her, which is the whole point of the ADA, right, is that they make a decision without considering that information because it's not going to impact them, or they can't take it into consideration. So no, she shouldn't tell them. And two, if she has a seizure on the job afterwards, then she's already hired. They've hired her because she otherwise qualifies, and then they would have to work out a reasonable accommodation for her if she needed to, for instance, knew some triggers, or if she knew that a seizure was coming on. Some people have triggers for seizures. Some people, can begin to tell when they're coming on because of the experience they go through with them. They would have to provide her reasonable accommodation. They can't fire her. They can't reprimand her. They can't discriminate her against her in other ways. They can't move her out of the job as long as she's able to do the essential functions of that job. All they can do is give her reasonable accommodations. Whether they'll be happy about that or not, quite frankly, I don't care. That they can't do anything about it. I mean, that's the whole purpose of the law, is it's not there to make you happy, it's there to protect people with disabilities. So no, I would never volunteer that information. Oh, yes.
The HIPAA law is actually protection for having to disclose health issues. Is that part of what you're saying? They don't have a writing on it. You have to disclose it. That's against the law.
Right. So the gentleman in the back is asking about HIPAA. So I also do a lot of presentations on HIPAA. And people get things confused regarding HIPAA. So let me tell you, everybody knows HIPAA partly because everybody throws the word around all the time. We hear it all the time now. We can't do that because of HIPAA. We can't give you that because of HIPAA. We can't tell you that because of HIPAA. I mean, I do a presentation where I start out with a guy goes to the doctor, and the doctor says, well, I can't tell you about your own medical record because it's not authorized under HIPAA. I mean, that's how much people protect HIPAA kind of health-related information. So you are correct that HIPAA does not allow certain covered entities to disclose healthcare information about individuals. But the healthcare entities that HIPAA covers are healthcare entities. It covers hospitals, nursing homes, treatment facilities, counseling places, mental health and behavioral health institutions. It doesn't cover schools, it doesn't cover the police, it doesn't cover private employers, it doesn't cover prisons. And yet I hear people from those institutions yell HIPAA all the time. And they're wrong, 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 and wrong. Does that mean that they can disclose your private healthcare information? No, but it's not because of HIPAA, it's because the ADA doesn't allow it either. And neither do certain other laws. The IDEA, FERPA doesn't allow it. There are all kinds of rules, regulations, and policies that don't allow releasing private and confidential information, not just HIPAA. So in a healthcare setting, it would be HIPAA. In this setting, though, you'll see part of this presentation will tell you that if medical screening, like we were just talking about, is required for part of your job, part of the requirement under the ADA is that they keep the medical information that they have gained about you in your employment application process separate and apart from all of your other employment records. And the reason they do that is because employment records are discoverable and can be passed on to other employers for your history of employment. For history of employment purposes, they're also disclosable under EEOC standards and other things in case you have employment issues that you later want to sue about. And those health records should not follow them around. So they have to be kept separate and apart so that they can be kept confidential. In this case, it's under ADA. In some cases, it's under HIPAA. Yes? 504 plans, yeah, so, and if they're applying for colleges, typically what will happen if they only have a 504 plan, which differs from an IEP, and we'll talk about that when we get to the IDEA, but in healthcare records, they usually also keep medical records separate from educational records. Those are kind of covered under FERPA, which is another law that doesn't actually have to do with, it's an education law, it doesn't have to do with special education, which is the IDEA, but yes, it's the same kind of regulation. Okay. So reasonable accommodations once you get there with an employer and you get hired and you have a seizure and you get a reasonable accommodation, some of the things that they may do for you, if they're considered reasonable, and reasonability you will find is a slippery slope and has to be determined on a case-by-case basis, but things like allowing you to have an interpreter on staff. If you are in a wheelchair, having a ramp built so that you can get into your office. If there's a no animal policy, they break the policy to let you bring your, service animal with you. One of the laws I don't talk about that's heavily implicated under this is the FMLA, the Family Medical Leave Act. So if, for instance, you had a seizure and during your seizure you fell and hurt yourself and you had to take some time off work and you didn't have any sick time accrued yet because it was a new job, you could still rely on certain protections under the Family Medical Leave Act. And in those circumstances, they'd have to hold your job open until you were able to come back to work, even if you didn't have vacation time accrued. And if your job had to be filled because it was a employer of, say, 16 people and they fall into the 15 category, but not so big that they were able to fill the void without you, then they have to put you in a vacant position if they can when you return so that your job is protected upon your return. They have to provide readers and interpreters, and they have to make sure that not only the work building is accessible, but your workspace is accessible. One of the things many of you may have seen, and workplace environments are doing this a lot now, is these ergonomic tests. Have you seen people from your HR department come around now and do the ergonomics, and you see people now have the standing desks because it's better for their backs, and they stand up and down during the day, and they have the special chairs and the ergonomic keyboards and all of that sort of thing so that we can all work more than 10 hours a day for our employers and not get carpal tunnel. This is why. So I think we already covered this, that during a job application, your employer cannot ask you if you're disabled, and if it's evident that you're disabled, they can't actually ask you the extent or nature of your disability, and they cannot require you to take a medical exam unless everybody is required to take a medical exam. Okay, so let's move on. I know we had a question over here about Section 504 regarding education, and so the law that covers education in particular, and this hits children mostly. We see it because the free public education, free accessible public education is the big key word, but it also goes into higher education. You were talking about transferring records to higher education, so it does cover that as well. The Individuals with Disabilities Education Act requires public schools to make available for all eligible children a free and appropriate public education to all children with disabilities, and they have to do it in the least restrictive environment, and they have to keep those kids in the same classrooms with non-disabled children. So what does that mean? It means that if your child goes to public school, it used to be, some of you may be old enough to remember, that it used to be kids who had severe disabilities didn't go to public school at all. A lot of times they didn't even get educated. 50 years ago, 60 years ago, whenever, that kids didn't go to school if they were disabled. They didn't have special buses to get the kids to school. They didn't have accommodations at the school place in order to take care of kids who needed special activities or special procedures or special education or special accommodations. Then the law changed and they started making accommodations for the kids, and the kids were all sent to these special classrooms. And so all the kids with disabilities went into the same classroom and all seemed to have the same sort of educational plan. And now we've realized that none of that works, and kids need to be integrated with their peers and be in the least restrictive environment possible in order to learn with their peers and develop social relationships. So the IDEA requires that when kids are in public school, they get the same education as everybody else. And if that means that the school has to spend more money and resources to make sure that those kids get an education just like their peers because they need some special assistance, then they're required to do that. You will see here that just like with the ADA, reasonable accommodations are required. In this case, it's under 504. We'll talk a little bit about IEPs. I'm sure everybody's heard about them. They're all over the news these days. Special education is a big deal, and I see the hand in the back. And I'll tell you a little bit about the difference between a 504 plan, which is when kids have disabilities but don't require special education issues, but they do require accommodations, either changes in their schedule or the way that they go through their classrooms or modified schedules during the workday or over the summer, and IEPs, which require special assistance in education. What was your question?
So say a kid has absence seizures, or missing words and things like that, there's a smart pen that will actually help the kid record and take notes. Does the school have to provide that?
Well, it depends. So here's the deal with the schools, is the schools have to do whatever is reasonable and appropriate. So they don't have to provide that pen necessarily if there's something else that will provide the student an adequate resource to be able to make up for that deficit. So for instance, let's say we have some wonderful technology that allows, if every child had this $15,000 or $20,000 computer that could capture all of their notes for them, make sure that they never missed a day of schoolwork, make sure that they'd never have to type, they'd never have to miss a class. That would be great, except we probably couldn't afford it. If the kids could get the same benefits, even if they're not exactly the best choice, the school isn't required to provide the best alternative. It's only required to provide an adequate alternative. And this is where we get into some debates between parents and schools as to what's adequate and what's the best. Because as parents, we all want the best, because that's the only thing that's adequate for our kid, right? Is the best. That's how I feel. But the schools feel differently, and a lot of times what happens is you hear the schools are not only providing not the best, but sometimes they don't even have the resources to provide what's adequate. And we get into a lot of fights about whether or not, first, do kids get the IEPs they need, and then second, are the IEPs being implemented the way they're supposed to be so the kids are actually getting the free and appropriate public education they're supposed to get. And sadly, the answer to that is often no on both counts. But there's a new program here in town, if any of you are interested in it, at the Arizona Center for Disability Law is now partnering with Arizona State University College of Law to make sure that all families who have children in special education programs get free legal representation to make sure their IEPs are implemented as needed. So let me know if you need any information on that. The question was, is an employer required to provide a place of rest for post-seizure activity at work? And the answer is, if it has been determined that having a quiet space for rest after a seizure is a reasonable accommodation, then the answer is yes. Of course, the issue is always who determines what's reasonable accommodation. A lot of employers simply will provide you what you're asking for because the consequence of not doing that and going through an EEOC employment discrimination activity simply isn't worth it. But some employers don't feel that way, and I'm sure many of you have run into situations where you ask for something that you think is really reasonable, and you don't get it, and then you don't know what to do, and we'll talk about what your remedies are toward the end of the presentation, because there are some places that you can go for help. We talked a little bit about free and public education, meaning regular classes, using regular classes with related aids or services and special activity related services. And that can be done, those can be provided either in the classroom, in special classrooms, or at home. Some kids require tutoring at home or other accommodations at home for lots of different reasons. And if that is the appropriate educational setting for that particular child, then the school is required to send somebody to the home to provide that to them. I think we've covered a lot of this. Yeah, so basically, this is the backup for the IEP, which is that educational institutions are required to provide an evaluation and assessment of every child with special needs, including those with epilepsy or other other disorders that may impact their education, and provide an individualized education plan that will accommodate their special education requirements, including the setting they have, the activities they have, the resources they have both in the school and outside the school to meet their educational needs. They're required to document those in something called an individual education plan, an IEP. They're required to have a meeting about those on a very regular basis, and there's supposed to be a team of people, which includes the child's parents, the child's teacher, the child when it's appropriate, not always, but when it's appropriate, an authorized person from the department who knows about the special education and advisory services, as well as anybody else the parents or the agency believe are appropriate for that particular situation, yes.
Is there a particular age when it is appropriate for the child? Is it like under the specific age?
The question was, is there a particular age when a child may be appropriate to include in their own individual education plan, right? There is not a cutoff. Like you'll find that there are a lot of laws that we have in Arizona that say, you know, when a child turns 12, they get to, or when a child turns 14, they get to. The IDEA does not include a hard stop like that. So some kids, it may be appropriate to include the child in an IEP when they're 10 years old because the issue that's being talked about in the IEP is the child's emotional reactions to certain stimulus in the classroom. And only by talking with the child are you going to be able to see his reactions to some of the issues that are coming up. Other times it may not be appropriate ever to have the child there, and sometimes it may only be appropriate during parts of the meeting because you're talking about things that you need the child's input on. So there is no hard stop on that, and you have to kind of work that out with the school. Yeah.
Or they will turn and tell them, I'm sorry, we don't have anything available to, you know, aid it to go on with them. Otherwise, legal stance from parents.
Sure. So the question was, if you have a child with a disability who, for example, has an aide, a classroom aide with them, and then you are faced with going on a field trip, right? And the family is not notified prior to the field trip, either the field trip is coming up, but that the aide won't be available. Field trip day comes around, and the aide's not available to attend the child during the field trip. Child ends up not being able to go on the field trip. What are your recourses? Isn't it required that the attendant be able to go with the child on the field trip? And as with almost all questions under the law, the answer is, well, it depends, right? It depends on the field trip, it depends on the child, it depends on how the aide is assigned to the child. So sometimes educational aides will be assigned to the child for classroom activities and only for classroom activities rather than extracurricular activities. You have to, if you want that to be part of the IEP, you're going to have to get the school to agree to that. But you're also going to have to be careful because their language is going to be very specific. Field trips are broad. Sometimes field trips simply mean leaving campus. So I've seen the situation where the field trip, and anything off campus is a field trip, just so you know. The field trip is walking down the block, you're 2 blocks off the school, and you're going to look at all of the nature in the park. Everybody's going to pick a flower and come back and do an art activity. That's a field trip. An aide may be able to accompany your child on something like that. But they may not be, depending upon who the aide is and what the insurance coverage is that has the aide there with your child. But I had another parent who wanted their child to go, an aide to go on their child's junior high school trip to Disney World with them. And they wanted the school to pay for the aide to go to California for 3 days. The school chose not to do that. They told the parent if the parent wanted to go as the aide and accompany the child, the parent could do that. But that's one of the areas you get into kind of some disagreement is they're not going to put on an IEP that if the child has an aide, the aide must always accompany the child on a field trip because field trips vary widely. So it's something you're going to have to negotiate with the school. Same story on extracurriculars, but if the extracurriculars are done by the school, it's a little bit different than if the extracurriculars are done by private, like extracurricular activities. So for instance, when the YMCA does the extracurricular activities and it's not through the school, the rules may be different. Okay? All right. Okay. And then, of course, the school must establish due process procedures for any of you who have kids with special special needs, you know that the due process procedure is where when the IEP doesn't get followed and the aide doesn't show up on the field trip and you don't get the accommodation and you didn't get the change in classroom and that computer that you've been promised all year long so that they could actually take their own notes never shows up. How do you get the school to move on that and protect your rights? And that's called a due process proceeding. And if you can negotiate so that you don't ever have to go to one of these, that's great. But due process proceeding is the administrative equivalent to going to court and having your case heard so that you can force the school system to do something for your child. And finally, we're going to talk quickly about the Fair Housing Act, and I know I'm probably already running long, and I apologize for that. I've been trying to talk really fast in case you haven't noticed to get you out of here, but I will take questions afterwards if you're interested. Fair Housing Act prohibits housing discrimination on the basis of all kinds of the regular things, race, origin, sex, gender discrimination, and on disability. And what does that mean? That means that if you are disabled and you have any kind of recognized disability and you want to rent or buy a house, and renting or buying a house includes qualifying for financing, qualifying for zoning permits to build ramps and other things around your house, then they cannot discriminate against you. No one can discriminate against you based on the fact that you have a disability. So if your neighbor's HOA doesn't like the fact that you're going to have a ramp up to your front door, too bad, right? Too bad. They don't get to discriminate against you for that purpose. If your neighbor doesn't like the fact that you have a dog and it's a pet-free neighborhood, but you have a dog because the dog is your service animal, then too bad for the neighborhood. There are reasonable exceptions required for everybody with disabilities in fair housing, and if they don't make those reasonable exceptions, it's very similar to the reasonable accommodations, then they too can be found to be in violation of Section 504 of the Rehabilitation Act as well as the Fair Housing Act. And this coverage includes both private housing, so it doesn't matter if you are buying or renting from a government or through a VA loan or an FHA loan, or if you're simply renting off of somebody out of a rental, a rental magazine or off Craigslist or however people rent, makes no difference if it's private, if it's government, or if it's HUD housing, federally assisted voucher type housing. It must not be discriminatory based on disability. And it also requires that you are permitted to make reasonable changes for accessibility to the property. Now, if you are renting a property, you can't require that your landlord pay for the renovation. So if you need a ramp and you're renting, you can't require that your landlord build the ramp, but you can require that your landlord not prohibit you from building a ramp if you need it. And this includes things like installing guide bars in houses for people who are blind, putting in ramps, putting in modified bathroom fixtures, or even building a fence in your backyard if you have a pet. I know I went quickly. I know we covered it at a really, really high level because we had a short period of time. But if anybody has additional questions, I'm happy to take them now. If not, I can leave my information with you. I do lots of presentations, and we try and put out a lot of information to the community. My firm feels very strongly about being able to provide legal advice to people who need it. And so if you find yourself in a situation where you'd like to ask questions or come to another presentation, I'd be happy to do that. But for right now, I'll take questions if you have questions now. If not, Suzanne knows how to get in touch with me. Yes, Suzanne.
We get a lot of calls from people who state that they were terminated and they feel that it's because it's just coincidentally after they have
A seizure. Mm-hmm.
But they're told that it's because of some other reason.
Right. Okay, so Suzanne was saying that the Epilepsy Foundation gets a lot of calls from people saying that they had been terminated by their employer. Their job had been terminated, and it just coincidentally happens to be after they've had 1 or 2 seizures on the job. And employers, of course, are wise and know they can't fire you for having a seizure, so they come up with some other reason for your being fired. And of course, that happens with all kinds of disabilities, not just epilepsy, but that happens quite frequently. So what is your remedy under those circumstances? The very first thing you should do within 180 days, please, is go right down to 13th Avenue in Washington and fill out an EEOC discrimination complaint form and get a right to sue letter. So the Equal Employment Opportunity Commission is a federal commission run by the U.S. State Department that protects disability as a protected class, and if you feel that you have been fired because of a disability, that is a discrimination act, and the EEOC will do an investigation. And at the end of the investigation, if they find any information that leads them to suspect that discrimination was part of your reason for separation from your employer, they give you a right to sue letter, and that right to sue letter is the only thing that allows you to then go see an attorney and file a lawsuit against your employer. And typically, if you have that right to sue letter, you end up not suing your employer, you end up settling, because when you have the right to sue letter, it means you probably have enough information to prevail on a lawsuit. But you have to do that within 180 days. Anytime you have a federal claim like that, there's something called a notice of claim period. They make it very short because they're like, listen, if you know you were discriminated against, you're going to know quickly and you need to move on it. We don't want to have all these claims lingering forever and ever. So just remember, it has to be within 180 days of the time that you were discriminated against. Okay? Yes?
Once you submit that with the average time that you research.
Yeah, well, it depends. It depends upon how much they have to research, how many people they have to interview, what the claim of discrimination is, how quickly they can get your files, and then how many suits they have going on at the time. They used to have this calendar that you would go on and you'd say, as of today, somebody who files, there's an average wait time of 65 days before we can get you a right to sue letter. Interestingly, the Arizona Corporation Commission does the same thing if you're trying to file for an LLC, but the government likes these little calendars. I don't know if they still have it, but it can be anywhere from 30 days to 180 days, or longer, depending upon what they have to investigate. Yes?
What if it ends up being, like, they say, okay, you do it a week afterwards, and it's going to be 160 days, 170 days before you get the information. You're still, because you submitted it?
Yes, as long as you submit it within 180 days, then you can get your right to sue letter. Once you have your right, so even if let's say you submit it on day 179, but it takes them another 180 days to get you your right to sue letter, you're still okay. Okay, but then once you get your right to sue letter, then you're into another set of laws, which means there's something called the statute of limitations. So if you're going to take that right to sue letter and sue, you have to do that generally within 2 years. Okay? Okay, yes? Okay, so in college, you don't get a free appropriate public education, but you do get accommodations under 504, so I'm glad you brought that up. So what that means is if they need extra time in testing, so what I often see at the College of Law, we have students who need this, is oftentimes they need to have a private room for testing because there are too many distractions will impact their test scores. They need to have a certain amount of quiet, so you can't have them in the same building as you would with somebody else, or at least not at the same times. You have to have the door closed so that they can have, they can concentrate. Some students have to be able to take their tests on a computer rather than writing because of certain disabilities. Some have to do it the other way. They can't be on a computer with a flashing screen. They have to be able to handwrite their tests. Some students will need a reader for them in order to be able to know what the questions are and then be able to write them. Some students may need somebody to write their answers for them. So whatever those accommodations are to make sure that they can have, they can equally participate in higher education, then that's what they'll get. There are no IEPs in higher education, but the accommodations under 504 apply equally. Okay? Yes? Yes, it includes everybody. Yes. Yes. Yeah, typically what will happen is the person who needs the extra time and the university will work that out. And you'll go to most college and university campuses have a disability rights office. So if you didn't know that, you should look for that, because I get a lot of questions about that at the College of Law, and I say, well, you have to go to the Disability Rights Office. And they go, you have a Disability Rights Office? Well, yes, we do, and most colleges and universities do. So ask there, because what will happen is they will do an assessment and get you identified as a student that needs special accommodations. And then once they've done that, usually the teachers and other people involved in the school will follow along and be as accommodating as possible. It doesn't mean that they will always accommodate your needs. I did have a client one time last year who was requesting what the school believed to be unreasonably long extensions of time. So the school thought, we'll give you 2 extra days. Every student is given 5 days. We'll give you 7 days. They believed that was reasonable. The student wanted 2 extra weeks, in essence, 3 times what the other students got. She did not prevail on that request, but usually they're pretty good about working with you. Okay, yes?
Just knowing the IEP, I mean, as far as the disability services within the college setting, they usually may give like time and a half, like 60 minutes.
They'll give you 90. Mm-hmm.
Just varies depending on the different
Right.
places. And if you're not diagnosed beforehand, you have to pay to conduct the diagnosis.
Yeah, so she was saying if you don't already have a diagnosis when you get to a college or university that would otherwise qualify you for a 504 plan, you have to pay if you want them to do the assessment. But you can also go through a private practitioner and get your own assessment, or if you have an assessment that simply hasn't been transferred in, then you can bring it in. Yeah. They'll do one for you. Yep. Right, right. Okay. Yes? This lady asked, if I'm filling out a job application and it says, and I check, no, I do not have a disability, but then I have a seizure later, can I get fired for not being honest on my application? And my answer is, don't answer that question because they have no business asking if you have a disability.
It's an online, and it doesn't give you the option, yes or no.
You should, seriously, I would call the EEOC and let them know that there's a discriminatory job application. I absolutely would.
Don't know if they're going to bypass it anyways and go, well, we're not going to give you an interview, we don't have people or job.
You know what you could do is just go back to them before you finish that, before you do the application. Just stop the application and call them and say, I noticed that your application is discriminatory because it asks about disabilities. And I was just wondering if you'd want to change that application or if you'd like me to inform the EEOC of your application procedures. Which is what I would do. Okay, any other questions? All right, thank you.
Thank you, Victoria.